Yan pa rin, sir. Binago ko lang.
Your slides and your video.
Okay.
So we can.
Kasi yung webinar natin is under UMIST eh. Pero yung mother account is under RMC.
Okay.
Apo, sir. Yes, sir.
Try sharing the lecture of Alessandro so we can test if Alessandro can try it.
Okay, sir.
Can you hear me?
Yes, we can hear you.
Yes, sir. We can hear you, sir.
I've sent you the video by WeTransfer, but it's taking now more or less 8 minutes more from now. It's uploading now.
It's okay. Anyway, we still have time. Anyway, Alessandro, let's try sharing your lecture. Let's practice sharing the slides. You can click on your share.
Yeah.
Yes.
Do you want me to try?
Yes, please.
Okay.
JD, are you there?
Let me try.
WeTransfer. WeTransfer.
Good morning. Can you see it? My name is Alessandro Carrara.
Yes, sir. We can see it.
Yep.
Can you also listen the audio?
Yeah. Pero may...
The patient positioning is quite similar to. How is it? Is it good?
Sir, can you make the screen bigger?
Yes, for sure.
Share yung isang tao.
Can you make it louder also, the volume?
Just above the umbilicus. And the first step of this depression is reduce the gastric fundus into the abdominal cavity.
May konting delay din.
A large hiatal hernia. How is it good?
Good.
Good, okay.
Good. It's good, Alessandro.
Very good.
Alan, can I check my video because I've hyperlinked it? I just want to make sure that it comes on screen also.
Yes.
Jadip. Hi, Jadip.
Hi, Alessandro.
How are you?
Good, good. Nice to see you over the net.
Me too, my friend.
Diba meron akong keynote PowerPoint. Pag tinigil ko na yun, makikita nila.
Can I share my screen?
Screen ko yung
Yes, sir. You can share your screen, sir.
Maraming pagpipilian na desktop. Alin dun yung
Pili mo yung play screen mismo.
Pwede ka ba mag-message sa kanila? O hindi?
Na.
Yung mga nag-aantay.
My screen?
Wala.
Pwede for a moment. Wala. Hindi pwedeng ganun, no?
Wala. Pwede. Wala tayong waiting room.
Can you see my screen now?
Yes, we can see your screen.
Okay,
yes,
I'm going to move it to my hang on, I'm going to move it to my video and see whether the video plays.
Naka-hyperlink lang. Lalabas ba yun, Arlene?
Okay.
I-share lang naman yung screen.
Okay, can you see the video now?
There's no video.
There's no video?
I think you have to change the share screen to your video player.
Yes.
What video player are you using? Is it VLC or?
Wait, hold on.
You go down to share screen and then click on the.
No, okay, you are scared. New share.
Screen share, the one below.
Okay, so here.
And you choose there. Yeah.
So I have to choose this individually every time?
Yeah, I think you have to do that. Because your share screen is in a PowerPoint mode, so.
Yeah. So can you see now?
At present, no. Is it playing in your computer?
It's playing in my computer video screen.
Click again the share screen and look for the application that's using your video. Is it VLC or Movie Maker? Depends on what.
Because I have not started my video.
Oh, it's not? Wait. Arlene, pwede ba niya natin makita kung ano yung...
You cannot start your video because the host has stopped it. No, but
Okay.
Oh.
my video, right?
You can play your video anytime, sir.
Yeah, you can play.
Well, I'm playing actually.
Oh.
Hold on. Now,
Yeah, okay.
There,
Now we
there.
can see your
Now
video,
we can
sir.
see it.
We can see your video now, Charlie.
okay, so this is going to be a slight issue because I'll have to get out of it.
Yeah, you'll be transferring from your slide to the video.
Yeah.
Sir, can I start broadcasting na, sir?
Yes, please.
Okay po.
Charlie, the issue with this one is on hyperlink. You need to go out from your slide to the video. So we can just wait for it. It's okay. But if you can embed it into the lecture itself,
Yeah.
because it's just going to be,
So I can't play it via hyperlink, right?
No. You have to go out the share screen and then click on whatever program you're using to play the video.
Okay. I'm just going to make it run again and just test. Do we have time or are we going to start?
Yeah, okay.
You have time. We have time.
Arlene, please try and check if Surface is from Zoom. Oh, he's going to join in 20 minutes. Surface is doing something. It's okay. I'll prompt you, Arlene, on the phone, on text, on WhatsApp, once Surface is in. Okay? He's going to join in 20 minutes. So anyway, let's try if Rona is already in. So we have now 3 speakers inside. Indeed, Johan is here. How about them? Them is inside.
Sir, Dr. Rona Atas already here. Johan is here. Mickey Lugto is here. Most of our lecturers are already here, sir. And we currently have 27 attendees.
27? Ilan ang attendees mo? 27?
27 and counting.
Okay. Wayne also touched that he's going to join in 20, 30 minutes time. Still in the meeting. But we're still okay. So anyway,
Okay na, ang dami na, Arlene. Sa YouTube,
Currently, we
wala.
have 43
56.
attendees.
59.
59. Total.
59. Yeah, 59.
Total. Kasama panelist and attendees. Sir.
Okay. Dito, wala na naman papasok sa YouTube. Recording ka na, Arlene?
Not yet. Mag-record na ako?
Siguro pag maka-reach na tayo ng 150, play nyo na yung... Di ba may parang video commercial tayo?
Naka-post na, sir.
Naka-pause? Sige. Okay.
Oo, ito na yung ano natin.
Hindi, para makita rin natin yung dun sa recorded video.
Oh, okay. So, start na ako.
Password is...
Oh my GERD.
Ilan? May?
Alexis Tokovsky.
Kasi Dr. Lawen ko to. Nalilito na ako kung saan.
How long is this seminar?
Hello?
Hey, Alex. Si Mike yun.
Hello? Using your ano? Hello? Saan kayo?
Hi, sir.
Hello.
Hi, Mike.
Hi,
Hey, Doc.
sir. Ninong.
Yes po.
Johan, hello.
Hi. Hello.
Hi, Johan.
Oh,
Hello, Doc.
just found out that Johan and Mike are brother-in-laws, right?
Cousin-in-law.
Cousin-in-laws.
Talaga?
Small world.
Yes, sir. Lawen ko yung asawa ko.
Okay.
Okay, Arlene, the video is uploaded. Try to check the video of Alessandro. And if something's wrong during the playing of Alessandro's video, you can play it on your side as the host.
Okay, sir.
Thank you.
Pwede naman yun, no? Kunin mo na lang yung video, Arlene. Tapos pag...
Yeah, kung naka-ano na siya, na-send na sa akin.
Ikaw na lang mag-share screen para dire-diretso na.
Yep.
Every time na ano. Sige.
I'll just check. Okay, it's here.
Okay,
Ikaw naman ang hosting eh.
It's already 2:05, and we start with the presentation of Johan.
Sure, sir.
And the first one would be
Teka, kunin ko nga yung WeChat natin. Ano, WhatsApp natin.
one and then 40 is okay. Anyway, can we start with the lecture? Let's welcome everyone. Because it's going to be a long afternoon. We have a lot of lectures and we want to at least cover everything. And the lectures would have done. Some of our lectures have surgeries also, like Alessandro, JP, everyone.
Okay lang.
Anyway, we would like to welcome everyone. This is our fifth conference. This is our weekly conference of the Unified Basic Surgery Training Program of the three institutions. Coming from Quirino, Rizal Medical, and Batangas Medical Center. Included in the UMIST are institutions like among Orthopedias, JB Liga, Poly Garcia, SPMC from Davao, what else? Anyway, there's a lot of institutions also that would be included under the UMIST program, under one unified program. And we would like to welcome everyone again. Good afternoon. And I would like to take this opportunity to thank all our speakers, especially our foreign speakers, Alessandro Carrara from Italy, Joy Dick Rao from Singapore, Dr. Ata Lawanto from the country of Cosmetics. We would like to thank everyone for sharing your time with us. But later on, in a few minutes, 30 minutes time, Dr. Sarfaraz Bai from India will be coming in also to share their experience on the treatment and diagnosis of GERD. I would like to call on Dr. Ray Sarmiento, the chairman of Rizal Medical. Ray. Dr. Sarmiento.
Hello.
Yes, Ray.
Sorry, my video won't open, but I'd like to say good afternoon to everyone. Thank you to our guests, our foreign guests in this conference for sharing your time and your expertise in this teleconference. And I'd like to welcome everybody, and let's not make do with so much welcome remarks. Instead, let's start the ball rolling. Maybe I'll pass the mic again to Dr. Buenafe so that he can introduce the other chairman of the two other institutions that's part of this UMIST training program.
Thank you, Ray. Can I call on Dr. Abadi, the chairman of the Department of Surgery, Training and Medical Center. Dr. Abadi? Is Dr. Abadi already?
Dr. Silahan, sir.
I think let's call on Dr. Joel Silahe. Dr. Joel Silahe is the training officer of the department and also the MIS head of training and medical. Dr. Silahe. Dr. Silahe. Let's go first to Dr. Palines and then we can start, I think, Dr. Palines, some words of welcome from Dr. Palines. Dr. Palines, the chair of the Teleconference Medical Center. Osman, Dr. Palines. We're having some issues. Anyway, can we start now? The first lecture will be coming from the Rizal Medical Center. Dr. Miki Lukto. Dr. Miki Lukto is the fellow of the endoscopy unit of Rizal Medical Center. I'll now welcome Dr. Arlene Canyones and Dr. Alex Resurrection, our moderators for the day. Thank you.
Yeah. Our host for today is Dr. Allenbert. Dr. Allenbert.
Okay. This afternoon's conference is part of the weekly lecture series of the United Minimally Invasive Surgery Training Program. So for today, we will be starting our series on upper gastrointestinal lectures, focusing on gastroesophageal reflux disease. GERD is a chronic disease of multifactorial disorder related mainly to failure of the anti-reflux mechanism of the upper GI. Systematic review has pegged the prevalence at around 10 to 20% in Western world and is said to be of lower prevalence in Asia. The majority of patients with GERD will remain stable over time within the level of severity of the disease. However, a portion of these patients will have progressive disease with deteriorating anatomy and function with associated increase in symptom severity and decrease in quality of life. Our presenters today will be discussing topics ranging from diagnosis that will cover recommended diagnostic modalities and their interpretation to the treatment focusing on available laparoendoscopic surgical modalities, their indications, and the intricacies of the different techniques. We are very fortunate to have distinguished international and local experts joining us and sharing their invaluable time, experience, and expertise. For our first presentation, this will be on the role of endoscopy in GERD diagnosis and the available endoscopic management of GERD in the Philippines, and also the present some present exciting developments in these fields. Our first speaker received his training in general surgery from Rizal Medical Center and is currently the fellow in surgical endoscopy with the same institution. He is Dr. Paul Vincent Lugto. Dr. Lugto, can you start your presentation?
Good afternoon, everyone. I'll just share my lecture to you guys. So, good afternoon, everyone, and to all our foreign guests. I am Dr. Paul Michael Vincent Lugto, the current junior fellow of surgical endoscopy of Rizal Medical Center, and I would like to welcome you all to our fifth UMIST weekly conference. So today I was tasked to give a lecture on the role of endoscopy in diagnosis and treatment of GERD or GERD. I have nothing to disclose. So to start our lecture, let me start to give you a little background of GERD or the GERD. So the apparent late recognition of esophagitis as a widespread disease has given cause for much discussion. Surprise has been expressed at the relative lack of reference to it before the mid-19th century, and even thereafter it was noted to be rare. Numerous factors reflect the apparent obscurity of the disease until recently. These include a lack of the clear understanding of the anatomy and physiology of the organ, confusion regarding differentiation between its symptomatology and that of the stomach, and the lack of opportunity and technology to adequately study it. So in 1543, Dr. Andreas Vesalius, a physician from Brussels, printed this picture and produced an exquisite anatomic folio in which the relationship of the stomach and that of the esophagus. So in 1541, in a book by Gaidon, they stated that the esophagus is the way of the meat and the drink. So even its name is poorly understood and much conjecture exists regarding to the origin of the term. Although the name is considered to have originally derived from an old Homeric term for the gullet, meaning became transmuted to reflect a combination of swallowing and food, thus becoming interpreted as a tube that conveys food. So an 18th century British cartoon accurately attests to the wide public awareness and familiarity with the demons of GERD. So confusion as the source of visceral pain led to the evolution of a nomenclature that confused the origin of the symptoms with either the stomach, the heart, or even the brain. Indeed, 2 centuries later, the basis of esophageal pain is as little understood now as it was then. So in 1946, John Tilden Howard, the then secretary of the ASGE, had been vocal in pointing out the need to examine the esophagus. So on May 16, 1957, he elected to yield the floor to Dr. Basil Hirschowitz, who presented the first studies of fiber optic endoscope and advent of the therapeutic strategies for esophageal disease. Thus, the esophagus was no longer considered terra incognita, which means parts unknown or no man's land. So to start with the definition of the GERD, Montreal Consensus Panel was consist of 44 experts from 18 countries. So defined GERD as a condition which develops when the reflux of the stomach contents causes troublesome symptoms and or complications. So troublesome satisfactorily describes the negative aspects of the symptoms from a patient's standpoint. Montreal is in the title because the results of the study were first presented at the World Congress of Gastroenterology in Montreal in 2006. So ASGE would later expand the definition. GERD comprises a wide spectrum of disorders ranging from gastroesophageal reflux without significant clinical or pathological impact through to the more severe complications of reflux disease, including erosive esophagitis, Barrett's, and esophageal adenocarcinoma. So for the incidence of GERD, GERD has an estimated worldwide prevalence of 8% to 33% as reported by ISDE last 2008. And in Eastern Asia, the incidence is 2.5 to 4.8 before 2005 and increased to 5.2 to 8.5 from 2005 to 2010. In the Philippines, 2.9% to 6.3% between the two periods of 1994 to 1997 and 2000 to 2003 respectively. On the other hand, it is estimated that 11 to 12% of the general population from the Philippines have non-erosive reflux disease, or your NERD. So this was the prevalence 20 years ago. In 1999, this was the prevalence of GERD worldwide. So for our next slide, this was also included in the Montreal consensus panel, wherein they created its constituent symptoms, classified the symptoms as esophageal syndromes and extraesophageal syndromes. So GERD is also classified by Fass and Hoffman as NERD, non-erosive reflux disease, ENRD, or endoscopy negative reflux disease is just the same. Then for the second one is EGRD, erosive GERD, or erosive esophagitis, or erosive reflux disease, or reflux esophagitis. And for the third one is the metaplastic GERD, or your BE, or your Barrett's esophagus. So this is the traditional clinical spectrum of GERD. From a physiological reflux to a symptomatic GERD, which typically presents as heartburn or regurgitation, to esophagitis, into a complicated one. So the possible complications will be ulceration, hemorrhage, stricture, and Barrett's or possible carcinoma. So Fox and Forgax, which is both British, made a new concept of the spectrum of the disease of GERD. They call it GORD because they spell the esophagus as, they start it with O, so esophagus. So in the study of Fox and Forgax, they noted that from a normal esophageal lining, you can either have a negative reflux disease, normal endoscopy findings, or you can either have a low-grade esophagitis, which would later present as high-grade and would later present as peptic stricture, or you can have a short segment Barrett's to a long segment Barrett's, and which later on will proceed to a possible cancer or adenocarcinoma. So in this slide, it only shows that the extent of exposure to acid is not related to the presentation. If you look at the endoscopy negative reflux disease, the extent of exposure to acid is mild to moderate, but the symptoms is high high burden of typical and atypical symptoms. And in erosive esophagitis, the extent of exposure is mild to severe, but atypical symptoms of reflux, heartburn is prominent. And while in the metaplastic part, the extent of exposure is moderate to severe. However, the symptoms are mild and or are delayed. Also, I will put emphasis on the complications and the malignant potential. So for your endoscopy negative reflux disease, it can be negative all throughout your life, or it may not impair your quality of life. However, in your inflammatory, the endpoint will be a possible stricture. In the metaplastic part, it can be a malignancy. So the malignant potential of both the NERD or the ENRD is low. EE, same is low. But on the metaplastic or the MGERD is relatively high. So again, from the Montreal Consensus Panel, heartburn and regurgitation are the characteristic symptoms of the reflux syndrome. So gastroesophageal reflux is the most common cause of heartburn. So this pie chart only shows that there is no significant changes in the incidence of esophagitis in comparison to the severity of your heartburn. So again, this slide, they use the LA grading system for esophagitis. So the incidence of regurgitation and heartburn are unrelated to the grade of esophagitis. In 1976, Dr. DeMister created a scoring system to objectively measure GERD. This scoring system is also valuable in evaluating patients pre and post-op or pre-post-op therapeutic endoscopy. So the highest obtainable score was 6 and would present a patient with heartburn that interfered with daily activities. So this slide, you will see it later based on the endoscopic management. It will be done pre-op, then evaluated again post-op as to check for a measurement if the therapy was indeed successful. So as we all know, this is the pathophysiology of GERD. So impaired mucosal defense, impaired LES, transient LES relaxation, a possible hiatal hernia can be there, lying flat, drinking of alcohol or coffee, increase in your acid output by smoking or coffee, H. pylori infection, increase in your intragastric pressure because of obesity, lying flat, also decrease in gastric emptying time, can produce reflux, and also bile reflux can also present as GERD. So diagnostic studies not needed with classic history of GERD. Heartburn or regurgitation, postprandial, postural decrease with antacid. So no diagnostics studies needed. So start empiric treatment. Okay? So when is invasive test needed? Usually with patients with dysphagia, when you're entertaining with a stricture or a possible mass, you can request for a barium esophagogram. Or if you're entertaining really with GERD and you want to do a 24-hour esophageal monitoring of pH with patients with PPI failure or pre-anti-reflux surgery, you can do it. Also, endoscopy will be done generally for the alarm symptoms. So for symptoms of dysphagia, weight loss, odynophagia, anorexia, and bleeding. Also to exclude Barrett's esophagus and patients requiring chronic therapy. 24 hours impedance pH monitoring and acid perfusion test also warrants the use of a gastroscope. So from ASGE, when is endoscopy needed? Additionally, EGD is performed as part of a pre-op evaluation for anti-reflux surgery. Placement of wireless esophageal pH monitoring devices is an inherent part of various endoscopy anti-reflux procedures. This would later on be lectured by our partners from GI, Dr. Lawenko, as well as the esophageal manometry and or the multi-channel impedance testing. Also in patients with suspected extraesophageal manifestations of GERD, endoscopy is warranted. So this is the table that was listed by ASGE. So again, GERD symptoms that are persistent, dysphagia, weight loss, bleeding, a mass or a stricture, screening for a BE, persistent vomiting, evaluations of patients before or with recurrent symptoms after endoscopic or surgical anti-reflux procedures or placement of wireless pH monitoring. So again, there's another demister scoring, but this time it is not based on the symptoms. It is based on the pH monitoring. So they measure during the 24-hour esophageal pH monitoring, they monitor 6 factors: the percentage total time of pH less than 4, percentage upright time pH less than 4, percentage supine time pH less than 4, the number of reflux episodes. The number of reflux episodes equals to more than 5 minutes or the longest reflux episode. So esophageal pH monitoring is recorded to 24 to 48 hours at a time and is analyzed under standard components. As a global measure of esophageal acid exposure, demister score greater than 14.72 indicated reflux. So a DMS of less than 14.72 would indicate no GERD. DMS of 14.72 to 50 will indicate mild GERD. A DMS of 51 to 100 would indicate moderate GERD, and a DMS of more than 100 would indicate severe GERD. So GERD-induced esophageal injury from ASGO, so typically findings of reflux esophagitis on endoscopy such as erythema, erosions, ulcerations, strictures, and BE is diagnostic of GERD with a specificity as high as 95%. However, at least 50% of patients with reflux symptoms have normal esophageal endoscopic findings, or the NERD, or an uncomplicated GERD. So the accepted classification of reflux esophagitis by ASGE is the Los Angeles classification and the Savary-Miller classification. These two are the most commonly used system. So this is the LA classification of reflux esophagitis. So LA grade 1, more than 1 isolated mucosal breaks.
Hindi ko ma-start yung video ko, makikita tayo.
Less than 5 millimeter long. LA grade 2 is 1 or more mucosal breaks more than 5 millimeter that does not extend beyond the tops of 2 mucosal folds. C, more than 1 mucosal breaks bridging the tops of folds but involving less than 75% of the circumference. And LA grade D, more than 1 mucosal breaks bridging the tops of folds and involving more than 75% of the circumference. So again, this is an endoscopic illustration of the esophagus. So the figure A is a normal endoscopic findings. This is LA grade A, 1 or more break no longer than 5 millimeters. This is LA grade B, 1 or more mucosal break more than 5 millimeters that does not extend between the tops of 2 mucosal folds. This is LA grade C, 1 or more mucosal breaks that is continuous between the tops of 2 but less than 75% of the circumference. And letter E is presented as LA grade D, 1 or more mucosal breaks that involves at least 75% of the esophageal circumference. So this just presents the 24-hour esophageal acid exposure according to LA grade. So the increased exposure time of esophageal pH of less than 4 would result to a more severe effects on the esophagus. As you can see, LA grade D will uh, uh, a 20% time of esophageal pH of less than 4% would present as LA grade D. So this one, LA grade C and D predict high levels of nocturnal acid exposure. So the person, again, they measure the percentage time esophageal pH less than 4 and the LA grade. So the one in yellow is the daytime and the one in blue is the nocturnal time. The new Savary-Miller endoscopic grading is also accepted by ASG, but this is seldom used in pre and post-op evaluation of endoscopy. So a grade 1 is a single erosion or exudate. Grade 2 is non-circular multiple erosions. Grade 3 is circular, erosive, or exudative lesion. Grade 4 is chronic lesions. Ulcers, strictures, or short esophagus isolated or associated with grades 1 to 3. Grade 5 is BE, alone or associated with lesions grade 1 to 3. So I will also present the part of the hiatal hernia since the presence and size of hiatal hernia influence the clinical presentation, esophageal function, reflux profile, and degree of mucosal injury of GERD. So 96% of patients with long segment will also present as, and 72% of patients with short segment bad esophagus has hiatal hernia. 71% of patients with erosive esophagitis will have hiatal hernia, and 30% of patients with NERD. So this classification is also important because they will also use this as an evaluation pre and post-op or pre and post therapeutic endoscopy. So here classification for hiatal hernia relies in the endoscopic aspect of the gastroesophageal valve seen from a retroflex position. So here's classification is sometimes referred to as the flap valve score or grade. It is also sometimes called as grade esophageal flap valve score or grade, or mucosal flap valve score or grade. So they are just the same. So for the picture on your upper left is the Hale grade 1. So a prominent fold of tissue along the lesser curvature next to the endoscope. On your top right is Hale grade 2. The fold is less prominent and there are periods of opening and rapid closing around the endoscope. The picture on your lower left side is Hale grade 3. The fold is prominent and the endoscope is not tightly gripped by the tissue. And the picture on your bottom right is Hale grade 4. There's no fold and the lumen of the esophagus is open, often allowing the squamous epithelium to be viewed from below. So as I was previously mentioned, erosive esophagitis can later on proceed to a peptic stricture. So uncomplicated reflux-related esophageal strictures are typically located at the squamocolumnar mucosa junction and are less than 1 cm in length. So a long history of heartburn with intermittent dysphagia over periods of months to years without weight loss. So this will differentiate a malignancy from a stricture. So on barium radiography in peptic stricture, these patients are typically older and have long-standing GERD symptoms and Severity of reflux symptoms decrease gradually with development of esophageal stricture. So once a stricture has been confirmed, the challenge is to determine the etiology as benign or malignant by endoscopy. So a biopsy and cytologic exam is warranted. So BE is a pre-malignant condition in which the squamous epithelium of the distal esophagus is replaced by abnormal columnar epithelium, known as specialized intestinal metaplasia. So BE would later on be discussed expoundly in our next lecture series. So development of reflux symptoms at an earlier age, increased duration of reflux symptoms, increased severity of nocturnal reflux symptoms, and increased complications of GERD. So again, Barrett's esophagus, displacing of squamocolumnar junction proximal to the GEJ, intestinal metaplasia characterized by acid-mucin-containing goblet cells using combined H&E ASEAN blue pH 2.5 stain is detected by performing a biopsy. So we'll now move on to the endoscopic management for GERD. So endoscopic management for GERD. The basic principle of anti-reflux procedures employing endoscopic intervention aims to create a mechanical barrier to prevent primary pathophysiology in GERD. So PPE therapy to decrease acid output cannot provide a physical barrier or restore the LES function. Relapses in esophageal and extraesophageal disease are also indications for a more definitive treatment. So these three are examples of your endoluminal anti-reflux procedures. Reinforcement of the lower esophageal sphincter or LES by injection or by implantation. Example of which is your enterics, your gatekeeper, or your plexiglass. Second is your TIF or your transoral incisionless fundoplication or your EF or your endoscopic fundoplication. Examples of which are your Esophi X device or your MUSE, your Medugus ultrasonic surgical endostapler. Then lastly, the radio frequency energy delivery to LES using the Stretta device. So for the first one, the reinforcement of the LES by injection and implantation. There were numerous attempts to create an anti-reflux barrier by a bulking effect at LES. So devices such as Gatekeeper, Reflux Repair, and the Enterix were removed from the market because of unsatisfactory benefit from symptoms control or objective measurement of anti-reflux properties and various degrees of complications. So to cite a few examples of the lack of remarkable benefits and Nazar-Duz effect, Dr. Sikala et al. Presented the paper with the effect of endoscopic management of the lower esophageal sphincter using the gatekeeper. So as acid exposure time at the distal esophagus decreased from 11.7 at the baseline to 7.7 at follow-up. However, of the 9 patients, distal AET normalized only in 3. Proximal extent of acid events significantly decreased in all patients on follow-up, but it is still lacking in improvement in the traditional pH variables. Another paper that was presented is the complications involving the mediastinum after injection of Enterix for GERD. So this is a case series of 2 patients. So they have both of patients had mediastinal complications after esophageal injection of Enterix for which hospitalization was required. The 2 patients were similar with regards to clinical laboratories and radiographic findings, although the procedures were performed by 2 different endoscopies. But there are trained endoscopies. The one endoscopies already did 8 enterics procedure, and the other one already did 5 of it. So both patients develop fever, leukocytosis, and pleural effusion shortly after the injection of your enterics. So again, for our number 2 in endoluminal techniques in managing reflux is the TIF using the SO5X device. So it was introduced as an endoscopic substitute for surgical reconstruction of the LES, and it aims to restore the angle of His. It improves the anti-reflux barrier by reducing small hiatal hernias of less than 2 cm if present, and by creating above 2 to 4 cm in length with a more than 270 degrees circumferential fundoplication. So SO5X is a single-use device and consists of multiple parts. A tissue mold chassis in which it bends, an helical retractor, no, it anchors the GEJ during the fundoplication, an invaginator, it reduces the small hiatal hernia, and the stylets and the fasteners. This one will secure the fundoplication part. So for a short video, this will be a minute video only. So 2 endoscopies are necessary for this procedure. The first operates a gastroscope to provide visual guidance to the second, who uses the SO5X device to achieve fundoplication. So the gastroscope and the SO5X device are advanced to the stomach under direct supervision. Once in the stomach, the gastroscope is retracted back into the chassis and the tissue mold is flexed, exposing a dedicated opening between the chassis and the tissue mold through which the it can be advanced. The gastroscope is then retroflexed to provide an endoscopic view. So the helical retractor is inserted to the GEJ and will pull the GEJ part. Then, on suctioning, it will later on straighten on, and the tissue mold and the invaginator buttress this approximation from the gastric and esophageal sides. Finally, the stylet fastener assembly places 2 serosa fuse fasteners through which this newly formed fold. So the SO5X device is then rotated on its long axis, and the process is repeated 9 to 10 times until approximation is achieved around 270 degrees of the GEJ. So approximately 20 fasteners are used or are implanted during the procedure to create a fusion of the esophagus and the gastric fundal tissue. So this is an endoscopy of a post-SO5X device implantation. As you can notice, there is a the scope is tightly hugged by your GEJ. So for our next one is the MUSE or the Medigus ultrasonic surgical endostapler. So this endoscopic stapling system that creates a partial fundoplication using the anterior stomach of around 180 degrees. So surgical and anatomic principles behind MUSE are similar to that of the TIF or the SO5X, but the apparatus used differs significantly. So MUSE is made up of a single-use endostapler, a light source, and a control unit or the console. The endostapler resembles an endoscope and has a handle with a tip deflection controls, an 80 cm long shaft, and a 66 mm long rigid section in the mid portion of the endoscope shaft. So again, a short video to present how we use the MUSE. So this is the MUSE device. The tip has an ultrasound, a stapling anvil, an anvil screw, an irrigation, a miniature camera, illumination, insufflation, and a suction. And the tip will attach into that area in the shaft. So this device only use one endoscopist. So same principle as of that of the TIF, which you will use it 3 cms above the Z line. Then the bending tube will bend towards the shaft, and a console will guide you on the gap of the tissue of the gastric segment to the endoscopy. Look at this, the bending angle of 204 degrees. You can measure the bending force, the ultrasound signal, the gap is increasing there, and also the alignment pin and the unveil screws. So this is the part where they fire the staplers. So during a MUSE procedure, you usually use around 5 to 7 staplers to achieve a 180 anterior fundoplication. So for our next device is the Stretta device. This is different from your TIF because it uses the administration of your radio frequency energy to the muscle layer of the LES. So it reduces the number of transient LES relaxation and decreases the LES compliance. Another short video of the Stretta and how we used it. So the Stretta apparatus is made up of 4-channel RF generator and a catheter. The monopolar RF generator has ports to allow attachment. So an upper GI endoscopy is performed to measure the distance between the GEJ and the bite plug. Then a guide wire is then advanced into the stomach and the endoscopy is removed. So this is a blind procedure. And we will have 6 treatment levels, 4 antegrade and 4 retrograde treatment levels. So the level 1 is 1 cm above the Z line. Level 2 is 5 mm above the Z line. Level 3 is at the Z line. Level 4 is 5 mm below the Z line. Level 5 is 5 mm below the Z line. So we will now dilate the balloon and release the radio frequency ablation. So there's also a console that measures how many joules are you going to give. So this just presents the 6 points on where you will ablate. Then slowly you will deflate the balloon to achieve a tightness in the GEJ. So again, this is an endoscopy findings of a post-Stretta device patient. So to review, I found a meta-analysis for the use of those 3 procedures. So the endoscopic treatments of GERD by Rafael et al. So TIF using SO5X is associated with improvement in GERD symptoms, cessation or reduction of PPI use, reduction in esophageal acid exposure time, and clinical improvement. So they use the RESPECT trial and also there's another trial that they use in which they measure the Demister score using the pH from 33% to a normalized percent to a 23.9. So SO5X is relatively safe procedure with rare risk of severe complications such as esophageal perforation, bleeding, and pneumothorax. Then for the Stretta patients had a higher rate of decreasing their PPI intake. A study by Lipka et al. At 6 months decreased the rate of use of PPI from 78 to 40%. So in the meta-analysis, 165 patients from 4 RCTs, procedure reduces GERD symptoms and improves quality of life scores up to 8-year post-intervention. So with over 15,000 Stretta procedures performed, the most common adverse events seem to be minor, which includes dysphagia, danophagia, hoarseness, epigastric pain, and retrosternal discomfort. So for the Muse, Muse produced a significant decrease in the mean esophageal acid exposure time. So a 4-year study by Zacharel et al. So a total of 66 were enrolled from 6 international centers. So they note a significant decrease in the mean EAE time from 10.9 to 7.3. There was significant difference at 6 months compared to baseline when looking at manometric findings regarding LES pressure, LES length, and peristaltic amplitude. So the most common side effect only is chest pain and sore throat. So Muse is a promising technique for TIF with additional advantage over the SO5X of having ultrasonic guidance and using only a single operator. For financial burden of these devices, as you can see, these are mostly single-use or disposable devices. So for your SO5X, it will cost you around $3,775, not including your staplers. So you will use around 9 to 10 to up to 20 staplers per patient. So that's going to be around 8,000 US dollars in total. For your Muse, the console is actually, you can lease it or you can buy it, but it will cost you around 47,000 US dollars. And you need to buy the cartridges for your staplers, which you will use around 5 to 10, and it will cost you around $3,000. And for the Stretta, the console itself or the RF generator cost is $30,000, and the Stretta catheter, which is a one-time use, will cost you around $2,700. So I don't think we can apply this in our local setup. Maybe some of the wealthy patients only can afford this. So in 2008, Inoue and the group from the Tokyo Live made a statement for the gastroesophageal reflux disease after POEM. So we all know that POEM is used for achalasia. So they presented a series of questions. Sorry, it might be a bit blurred, but I will read the important part. So what is the incidence of GERD after POEM? So their statement was POEM may induce GERD, but incidence depends on measurement. So what is the role of your PPI after POEM? So most patients with post-POEM GERD responds to PPI therapy. However, the indications for PPI are not well defined. So Inoue and the group later on provided the POEMF to address the GERD-induced post-POEM. So this is the per oral endoscopic myotomy and fundoplication, so a novel notes procedure. So to give you an idea of the procedure, this is how it looks like. Sorry, I didn't got the opportunity to get a video. So I will just put on illustrations on how they do it. So conventional per orem POEM is completed at the anterior wall of the stomach. Next, on your upper left, we'll note that the peritoneal cavity is accessed through the submucosal tunnel. So entry into the peritoneal cavity, distal to the diaphragm. A full thickness myotomy is carried out along the anterior wall of the stomach tunnel in a 12 o'clock orientation. This defect is enlarged using a triangle tip knife and a coagulation forceps. So the endoscope is advanced into the peritoneal cavity to the left lobe of the liver and the anterior side of the stomach. So the picture on your lower left is the anchoring of your envelope. Once you have already identified which part of the anterior stomach you will pull, so you will start anchoring the envelope with endoclips to the anterior wall of the gastric fornix and the EGJ. So step 2, the envelope is fixed to the anterior gastric wall and to the distal end of the subcutaneous tunnel with clips. Then proximal anchor clips at the distal end of the submucosal tunnel to close the whole esophageal mucosa. So the closure of the envelope, creating a fundoplication. So by closing the envelope, the distal anchor clips are pulled towards the proximal anchor clips. The envelope is closely tightly and anterior partial is achieved. So Inoue also introduced the ARMS or the anti-reflux mucosectomy or the ARMS. So in 2003, Professor Inoue reported a case of circumferential mucosal resection of the distal esophagus and cardia for high-grade dysplasia in a short segment Barrett's esophagus. In this case, the primary objective was complete excision of the Barrett's mucosa with high-grade dysplasia. So the patient also happened to present with repeat chest pain, Demister score of 5 with significant hiatal hernia with a mucosal flap grade 3. So a circumferential mucosal resection extending to include a 2 cm wide portion of the gastric cardia was completed to ensure an adequate distal margin to the Barrett's esophagus. So initially, this was done in a Barrett's esophagus, and they later found out that this was effective also in treating your GERD. So this was the patient that I mentioned with BE. So on your left, this was the post mucosectomy. This picture represents appearance at 3 years. So a tight gastroesophageal junction, convergence of 3 gastric folds was observed. Then on your lower left is a picture more than 10 years. Then a picture on your lower right is the chromoendoscopy, which with Lugos solution demonstrated well-stained squamous epithelium with neither recurrence of esophagitis nor your Barrett's esophagus. So the study, this was the demographics of the study. So age of 56 with esophagitis, LA grade of B. Okay, so this is how it would look like. The arms. So on picture on your upper left is before the arm. So endoscopy and retroflexion demonstrated significant hiatal hernia with a Hill score of 3. So chest pain and regurgitation were prominent in this case with a Demister score of 5. So on picture on your upper right, immediately after the procedure, endoscopy and retroflexion used 2/3 circumferential artificial ulcer, and the ARMS was centered at the lesser curvature. This one was modified with not using a mucosectomy of the whole circumference. They use a crescent shape like mucosectomy. Then the results are also promising. The picture on your lower left is a picture of the EGD after 2 months. And picture on your lower right is the picture at 2 months with a, this is an antegrade view. actually. Okay. So just a short video of how the ARMSR is done. So first, they mark the part wherein they will proceed with the EMR, then put a dye, then we'll use a CAP EMR, endoscopic mucosal resection, and we're later on produce a, sorry, I have to forward it just to finish it quickly. So there you go. It will look like a crescent-shaped resection. So the results was promising. The Mr. Score, as you can see before, ARMS is around at 3, and after ARMS, it is around 0 to 1. And again, the flap valve grade from before the ARMS is 2 up, and then post ARMS, it's 0 to 1. So, anti-reflux mucosectomy last 2005 had also their
Can you go
complications.
on the conclusion so we can have, we still have a lot of lecturers.
Okay, sir. I will just.
Thank you, Mickey.
Thank you, sir. So to standardize everything, they used the ARMS. So so how should we select? Siguro this important na lang. How should we select patients for ARMS? So proper patient selection will always be considered. Patients with psychological issues and with hiatal hernia of more than 3 is excluded. So again, accurate pre-assessment endoscopy must be performed to sufficiently insufflate the stomach with good retroflex view to correctly assess herniation and evaluate the gastroesophageal flap valve. So they also tried to modify it by doing a bilateral crescent shape like to, and it will present as a butterfly shape resection. So this also provide promising results. So these are, again, new studies, the ARMA or the ARAT. So ARMA from Japan and the ARAT from Mexico. So these are ongoing clinical trials. This is the picture of the ablation, which will later on look like a post-ARMS. So in summary, there's still no definite guidelines on how to manage GERD after failure of medical management. Endoscopy is still important in pre-op and possibly intra-op evaluation in surgical procedures. So endoscopy also plays a huge role in post-operative surveillance as well as the success of surgery. So novel procedures such as ARMS or ARMA or ARAT can be applied to our local setting with regards to our healthcare system and financial capabilities. So the mentioned procedures would greatly add to our armamentarium as surgeon or as surgical endoscopies. So I'm sorry for taking time too much, and that's all. Thank you.
Thank you, Dr. Lugtu. We would like to acknowledge the presence of Dr. Sarfaraz Baig,
Thank you very much.
Dr. Wayne Huang, and Dr. George Yang. Thank you for joining us.
Thank you. It's a pleasure.
Okay. There will okay. Our next topic will be a talk on the use of high-resolution manometry and pH study in diagnosis of GERD. And our speaker will also expound on how we can understand these results from these diagnostic modalities. So she's a she received her fellowship training in gastroenterology and hepatology from Cardinal Santos Medical Center. Subsequently underwent subspecialty training in gastrointestinal motility from University Sains, Malaysia. She is currently an assistant professor with the College of Medicine de La Salle University Medical Center and the training officer of the Gastroenterology Fellowship of the same institution. And let us welcome Professor Rona Marie Ata Lawenko. Doctora Lawenko,
Hi,
okay.
Alembert. Thank you for the introduction. So let me just share my screen. Can everybody see the slides?
Yes.
Okay. So good afternoon, everybody. Thank you to the organizers of this lecture series, to all my co-panelists, Dr. Benafe, Arlene, thank you for inviting me. So today I'll be giving a talk on a basic and essential primer on high-resolution manometry and reflux testing with pH monitoring. So my objectives are to give a better understanding of the principles of pH monitoring and high-resolution manometry, how it is done, and touch on basic interpretation. Lastly, I would like to review the Lyon classification for GERD and the Chicago classification for the diagnosis of motility disorders. So after hearing the previous talk by Dr. Mickey, we know that traditionally GERD has the following phenotypes: non-erosive reflux disease seen in 70%, erosive esophagitis in about a third of patients, and then you have the GERD complications such as Barrett's. Clinical diagnosis is still the case in the absence of alarm symptoms that was mentioned earlier, and a PPI trial is a pragmatic approach. However, we do know that there is low sensitivity and specificity for a PPI trial in the diagnosis of GERD. And really the question of whether there is reflux may not be truly answered. And the use of endoscopy has been discussed very well, but I'd also like to share with you the Philippine guidelines wherein endoscopy is a must in these clinical settings, which I'll no longer go through. But now we see that there is a change in the nature and phenotypes of GERD. Newer classifications such as your reflux hypersensitivity and functional heartburn are now part of the spectrum of GERD. And also in the clinics, we do see a considerable overlap with other functional GI problems such as your IBS and functional dyspepsia. So the diagnosis of GERD may not always be straightforward. There are issues such as a failure of your PPI trial, a lack of correlation with your endoscopic findings. Patients may have atypical symptoms, and a subset of patients may have what is known as refractory GERD. And really the challenge is, how can we know if the patient does indeed have reflux? Or even how can we measure treatment success or failure accurately? And this is where the value of reflux testing lies. So this leads to the first part of my talk, which is the essentials on reflux testing. So the Lyon Consensus panel of experts in 2018 stated that multi-channel impedance pH study is the gold standard for detection of reflux, and it could be done using a catheter-based or a wireless system. So this was also mentioned earlier. pH monitoring actually started in the 1970s, and it uses a transnasal catheter that has a pH probe that is placed 5 centimeters above the LES seen in the image. And this position was considered to be the optimal depth to monitor distal esophagus acid exposure. Plus, it is high enough that slipping into the stomach is unlikely. And in essence, the test will check if there is abnormal acid reflux, which is defined as a fall in the pH to less than 4. And this pH level cutoff was determined because one, pepsinogen is converted to pepsin at this level. Symptoms such as heartburn also appear at these pH levels based on studies, and the normal esophageal pH is between 6 to 7. So this is what happens in a normal, this is what happens during a pH study. So here, if you can see, the baseline pH is at 7, and when gastric contents go up the esophagus, the pH drops. And when the esophagus clears the refluxate through a peristaltic movement, the pH goes back to baseline. So I hope it's clear. Now, what about impedance? So Z symbol represents your impedance, and it's the electrical resistance measured with an alternating current, and it's expressed in ohms. And it's inversely proportional to conductivity. So the more surface exposed, the higher conductivity and lower impedance. So in this image here, you can see that air has high impedance while food and refluxate has low impedance. And this is what an impedance pH catheter would look like. It would now consist of at least 6 impedance channels and 1 or 2 pH sensors, depending on the brand. And this kind of catheter will be able to measure not only acid, but all kinds of reflux. And here is a catheter with multiple impedance sensors. And if you apply the concept of impedance in the esophagus, when there's nothing inside the esophagus, your Z line or your impedance is constant and high because there's nothing inside except air. But then when you swallow and a food bolus enters, your impedance wave drops. And then when the bolus clears that sensor, the impedance will now go back to baseline. And then if you have multiple sensors, you will see that as a bolus goes down, the impedance will drop, and then it will go up in the first sensor, and then it will drop. And then again, it will go back to baseline. And it will happen in this pattern. So what you will see is what a normal swallow would look like. Now, the opposite happens when you have a reflux. So if you have gastric contents going up, the impedance will drop. And as you can see, all the impedance sensors was able to sense the reflux going up. And then when the esophagus through peristalsis clears the reflux event, your impedance will go back to baseline. And you will see this triangular shaped pattern. Now, if you have a reflux event that only reaches a few of the sensors, when peristalsis occurs, this is what the pattern that you will see. It's a shorter trapezoid-shaped pattern. So again, that's what a swallow, a reflux, and a reflux with limited proximal extent would look like. How about gas or air? So when you have gas, reflux, so usually such as when you belch, the impedance will go up. So the impedance will increase, and then as the air goes up, the impedance will increase and go back to baseline in this manner. So this is what again, that's a swallow, a reflux with limited proximal extent, and the last one is a gas reflux or a belch. And if you combine data from both impedance and your pH sensors, when reflux occurs, the pH and the impedance will all drop and go back to baseline. And if your pH is below 4, this is called an acid reflux. And here is another reflux, but you can see that the pH is between 4 to 7. And this one is what we label as a weakly acidic reflux. So I hope it was clear. And having said that, once a patient is advised reflux testing for the very first time, they should stop PPI for at least 5 to 7 days, H2 blockers for at least 3 days, and antacids for at least 24 hours. And the patient is placed on fasting for 6 hours prior. And of course, you have to make sure, you have to confirm indication, and you may even use a questionnaire such as your GERD cube. And the equipment that is needed is the software. You have a recorder, a French 6 catheter that has already been calibrated both to acid and alkali prior to use. So for the actual procedure, manometry has to be done because you want to know where the upper border of the LES is. You may spray a lidocaine or a numbing agent in the nostril. Then the catheter is inserted sort of like an NG tube, where there are number markings that will guide placement. And the most important thing is that the sensor should be placed 5 centimeters above the LES, which I mentioned earlier. After which you fix the catheter in place and you attach it to the recorder. Then you will advise your patient to record information such as meal, position, and symptoms or events in a diary for 24 hours. And then when they come back after 24 hours, you recover the data and you upload it in the software. There are minimal adverse events such as nasal discomfort, throat pain, and at times the catheter may be misplaced or even a technical failure may occur. So it's not a perfect study as these things can happen. And there's no strict contraindication except for outright nasal deformity or obstruction, such as a nasal polyp, which will hinder insertion. And this is a sample 24-hour pH impedance data generated by the software. And usually, more often than not, manual analysis is done, which does take a while to review. But what is essentially done is you magnify the test and you look for the presence of the following patterns that I described in the videos earlier. So you want to know if there's a reflux, a limited, proximal limited extent reflux, and you want to know if it's an acid or non-acid or even a weakly acidic reflux. So you look for events. And to interpret the study, the software generates these parameters, and the normal values are based on studies done on healthy volunteers. And I think the most important in this table is your acid exposure time, which was mentioned earlier in one of the studies. It's AET, which is the percentage of time when the pH is below 4, and an abnormal number is more than 6% of the time. Now, more than 80 reflux episodes is considered to be significant, and the Demister score, which was described and enumerated earlier, if you have a score, it's a composite score of the parameters generated, and a score of more than 14.72 means positive acid exposure. And the last row here is that you want to evaluate the temporal association between actual reflux or actual heartburn and symptoms to actual reflux episodes. And the software generates the symptom index and the symptom association probability complications. And if it's more than 50% and 95% respectively, then you have a positive, it's positive for pathologic reflux. And in essence, these calculations will be able to tell us the amount of acid exposure and whether symptoms are actually related to reflux events or episodes. Now, apart from the catheter-based studies, a wireless device to measure pH is also available. The Bravo pH monitoring system uses a capsule to collect data, and it transmits it via radio frequency to an outside receiver. And with this test, you can actually measure acid exposure beyond 24 hours up to 96 hours. And the figure illustrates the steps, which is you position the capsule delivery system through endoscopy and you apply suction, and then you release the capsule about 6 centimeters above the lower esophageal sphincter. And the second image is what it looks like in real time. And the clear advantages of a wireless system is there's better tolerance. It's better tolerated by patients. You have less migration rate because of a fixed position, and it also allows prolonged monitoring. However, disadvantage, of course, would include your cost. There's no impedance test with this kind of test, and the capsule may even dislodge early. Normally, it takes about 5 days before the capsule detaches on its own, but sometimes it could even fail to detach, which may require another endoscopy to remove it. And this is a sample result generated, and the red line is your pH of 4. And in the first image, you can see clearly that there were a lot of dips below pH 4, which is significant for acid exposure. And the image below is negative or no reflux. Now, going back to the Lyon Consensus of 2018, they basically recommend reflux monitoring or testing of a PPI in patients with unproven GERD and prior to anti-reflux surgery. And unproven GERD means absence of prior evidence of GERD and absence of a prior abnormal reflux monitoring. But they also stated that testing is also useful in patients with proven GERD on a PPI if you want to assess an adequacy of treatment. And proven GERD is defined as a prior endoscopic evidence of GERD, meaning esophagitis grade C or D and a Barrett's esophagus, or a history of a prior abnormal reflux test. And this is a better representation of what I just mentioned. So in the first arrow, you can see all the indications where you may want to do reflux or pH monitoring of a PPI, and then on a PPI if you want to check for adequacy of treatment. Now, the Lyon Consensus also summarizes the diagnosis of GERD in this flowchart. And a conclusive evidence of GERD is when you have these endoscopic findings plus an acid exposure time of more than 6%. Now, in the second row, you can see that if you have an AET between 4 to 6%, reflux episodes between 40 to 80, and LA esophagitis grade A or B, this is considered to be only borderline or inconclusive for GERD. Why? Because most studies noted that there could be inter-observer variability when you describe an esophagitis as grade A or B. And in some studies, healthy asymptomatic individuals may have an AET between 4 to 6%. So they categorize these parameters as being borderline or inconclusive evidence for GERD. Now, the last part in green, the last row, is if you have an AET of less than 4% and reflux episodes of less than 40, then this is the time that you say that definitely, or the possibility of GERD is unlikely. And the tricky part is the one in blue. So these pertain to your supportive findings when you're not truly confident whether a patient does or does not have GERD. You may want to look at biopsy and maybe check for things like dilated intercellular space. You may also want to look at symptom association, and you also consider manometric findings such as hypotensive EGJ, hiatal hernia, and esophageal hypomotility, which I will touch on later. But what is important in this row is that all of these are only supportive of a diagnosis of GERD, and these parameters and metrics, when taken in isolation, are not enough to diagnose pathologic reflux. And the reason why it's so important to answer the question of whether is there true GERD or not is because the test can and will redirect your management. And in this most recent Rome criteria for esophageal disorders, a patient with reflux symptoms but with normal endoscopy and had a subsequent pH test done which showed abnormal acid exposure on the study, then these are the patients that you truly categorize as having non-erosive reflux disease or NERD. On the other hand, a patient with normal endoscopy and normal acid exposure on pH study, but when you look at the symptoms, they had the positive symptom association probability. And these are the patients that you label as having hypersensitive or esophageal hypersensitivity. And the last one is if all else is negative, but you have a patient coming in with symptoms of reflux, and you label these patients as having functional heartburn. And the last two patients, those with esophageal hypersensitivity and functional heartburn, these are the patients that are poorly responsive to your PPIs, and you may want to wean them from PPI and even consider using neuromodulators, as they may have a better role in management. And I think in addition, you also want to make sure that you have a correct diagnosis, because before thinking of doing any invasive therapeutic intervention. So now moving on to the second part of my talk, which is the essentials on high resolution manometry. So why is it important to do a motility test? We know that the most common indication for a motility test is dysphagia. And some studies show about a quarter of patients with non-obstructive dysphagia may actually have underlying GERD. Likewise, non-cardiac chest pain, which is an atypical symptom of GERD, which is maybe seen in about 50–60% of patients, is also a symptom of esophageal dysmotility. Now, manometry alone cannot directly diagnose GERD, but it does provide vital adjunctive information. It's a measure of your EGJ morphology and your LES pressures. And we know, as explained earlier, that the fundamental abnormality in GERD is a problem with the EGJ barrier. And the motility testing would also be able to evaluate esophageal body motor function. And manometry has its roots in conventional manometry, wherein you have the catheters with very few sensors placed in the following region seen in the first image. And it uses the sensors to detect pressure wave changes. But now, with the advent of high-resolution manometry, there is real-time visualization of your pressures, and it's shown in a color plot, which we call pressure topography. And it's basically easier, and it makes for quicker interpretation. So why do you test? Again, apart from dysphagia and non-cardiac chest pain, you also want to do the test because you want accurate placement of your pH studies. And you also do the test for preoperative evaluation prior to anti-reflux procedures. And you also do this post-operative evaluation of patients who underwent some form of treatment for a primary esophageal disorder, whether for reflux or for a motility problem. And there are many catheters available, and shown here in this image is a solid state 36 sensor catheter. And similar to your pH study, you place your patient on fasting and you insert the catheter through the nostril, and after which you check for resting pressures. You administer 10 water swallows, and you may even do a provocative test such as a multiple rapid swallows, which I will briefly discuss. And this is an overview of the 10 wet swallows that you administer. So in manometry, basically the pressures are depicted as colors. So your low pressure zones are your blues, and your high pressure zones are your deeper and colors in reds. And now in the resting state, you can appreciate the green bar on top in the image below, which is your UES or upper esophageal sphincter, and the green bar below as your LES. And we know that in normal patients, the LES and the diaphragmatic crura are in line, and it shows up manometrically as just a single line of pressure. But in the presence of a hiatal hernia, you know that the LES is above the diaphragm, and you will see this in manometry as two separate pressure zones, which we call as dual high pressure zones, so as shown by the black arrows. And this is what a normal swallow would look like. The x-axis is your time. So if you break it down, you have the upper esophageal sphincter on top and the lower esophageal sphincter below. And the transition zone it's the zone which it refers to the zone wherein your striated muscle transitions to your smooth muscle. And what happens when you swallow? Your UES opens, and then you have peristalsis. And right about the time that peristalsis occurs, your LES should be opening. And if you add the concept of impedance, impedance here is represented by the purple color. As swallow progresses, there is clearance of food bolus into the stomach. And the last image is if you have the, here what you can see is the bolus is not completely clear, probably because there is a weak contraction. So in essence, a normal swallow would require a competent LES or LES that relaxes as well as intact peristalsis for complete bolus clearance. So how can we interpret and use the results? An HRM working group composed of experts, they convened in Chicago and came up with a classification that is currently on its third version. And these are the metrics that are used. But as a primer, the focus or the most important ones are the three: the IRP, the DCI, and the distal latency, which I will go through individually. So the integrated relaxation pressure, or the IRP, it's the most important metric in manometry, and it is a measure of your LES relaxing. So it refers to the lowest LES pressure during any 4 seconds in the area shown by the arrow from the start to the end of the swallow. And normally it should be less than 15. So this is very important. Your IRP should be less than 15. It's a measure of your LES relaxing. Now, the second metric is your distal contractile integral, or DCI, which is a measure of your peristaltic vigor. It's the strength, duration, and the length of contraction. And normally it should be between 450 to 8,000. Anything below that is either a weak or a failed swallow, while anything more than 8,000 we categorize as a hypercontractile swallow. And another metric is your distal latency, or DL. It's the interval between the UES relaxation up to the CDP, or shown here in the asterisk. CDP is your contractile deceleration point, which is basically the point wherein your swallow starts to slow down, and it corresponds to food entering the stomach. And normally your DL, or distal latency should be about 4.5 seconds or more. And if you have less than that, less than 4.5 seconds, you have what is called a premature or a spastic swallow. And if you combine the IRP, the DCI, and the distal latency, you apply it to this flow chart, the Chicago classification. And this hierarchy is divided into, the first one is your disorders of EGJ outflow obstruction, which includes achalasia. Second one is your major disorders of peristalsis, which includes your DES and your jackhammer esophagus. And then you have the minor disorders of peristalsis, which includes your ineffective motility and fragmented peristalsis. And the last is a normal pattern. But worth mentioning is achalasia, which is the esophageal motility disorder that we all know, and I think is the next topic on your lecture series. It's defined as failure of your LES to relax with swallows and absence of peristalsis in the esophageal body. And it's seen in both men and women in these age groups. And though unclear, a combination of autoimmune, viral, degenerative, and hereditary factors are postulated as the cause. And essentially, the gold standard for its diagnosis is manometry. Manometry is relevant because treatment success would depend on the subclassification that you're able to get when you do a manometry test. So achalasia, it's a disorder of EGJ outflow obstruction, as I mentioned earlier. It has 3 subtypes, which is likely related to possibly the various stages of the disease. And essentially, you diagnose achalasia when you have a high IRP plus, you have 100% failed peristalsis or just spasms. And in type 1, which is your classic type, you see here that there is no peristalsis, and you see the non-relaxing LES below. You don't see any relaxation, and the IRP is more than 15, it's 22. So there's no swallow despite your UES opening. So this is a classic type. Now type 2, which is the most common type of achalasia, you also see that there's no LES relaxation and no normal appearing swallow. And what you see are these 2 bands of green, which is what we call a panesophageal pressurization, which basically represent your esophagus compressing, trying to make whatever is inside the food bolus go down, but it couldn't because your LES is non-relaxing or the LES is closed. Now, the last type or type 3 is your spastic type. It's defined by high pressure spasms in the lower esophagus. So similar to your type 2, but this time there are more high pressure spasms. But again, there's no intact swallow. Plus, the LES is non-relaxing. So the IRP is elevated. Now, EGJ outflow obstruction by itself is another entity described in the Chicago classification. Again, it's defined by having a elevated IRP, but this time you see intact peristalsis. So in the image, you can see that the IRP is about 25 and 27, but you can see a normal appearing swallow. So this is worth mentioning because it does have unclear clinical value, but it may relate to the possibility of early achalasia, scarring, or even a reaction to chronic reflux. Now, the other major disorders I'll just go through quickly. They all have normal IRPs, but in distal esophageal spasm, this is where you see that the distal latency is short. So that's why it's called distal esophageal spasm, because you have repetitive spastic swallows. The jackhammer esophagus, again, you have normal IRP, but your DCI is high, so it's more than 8,000. And the last major disorder is what we call as absent peristalsis, which is wherein you have a normal IRP, but you have no or absence of swallows. And these are usually seen in patients with underlying connective tissue disease, such as scleroderma. Now, the two minor disorders are, number one, it's the ineffective esophageal motility, which is basically there are weak swallows, but your IRP is normal. And then fragmented peristalsis, which is, again, your IRP is normal, but you see these large breaks from the UES until the actual peristalsis. And if it's more than 5 centimeters, it's described to be fragmented peristalsis. And now, the most common manometric pattern in GERD is a normal pattern, but you may see these two minor disorders, that ineffective esophageal motility and fragmented peristalsis in some patients with GERD. Others include, you may also see patients with hiatal hernia, hypotensive LES, and even absent peristalsis. I mentioned multiple rapid swallows earlier. This is another test that can be done during manometry, and it entails giving 5 successive 2 ml water swallows, and it is a measure of deglutitive inhibition. It's a physiologic mechanism where there is inhibition of peristalsis until the very last swallow during a repetitive swallow. Here in the first image, this is a normal response wherein you see the UES opening several times without peristalsis, and then you see a compensatory swallow at the end. An ineffective or weak contraction after MRS is shown in the second image, and this may also be seen in GERD and is said to be a measure of your contractile reserve. And based on current data, the value of manometry lies in its ability to identify possible contraindications. It may tailor procedures and may even help predict outcomes such as dysphagia after fundoplication. A high IRP, weak or absent peristalsis, and even an abnormal MRS are some of the things you may want to look for in manometry prior to thinking of doing a surgery. But I think all of this may be better explained by our expert surgeons. Our local guidelines in the Philippines emphasize the value of testing with manometry and reflux studies prior to doing any form of esophageal surgery. But considering the procedure has been developed so long ago and it's relatively easy to perform, the problem in our setting is still availability and cost. And at the moment, there is only a couple of hospitals or institutions who have the test. And these hospitals have to cater to the 6 billion or more Filipinos. And another concern that we may need to have is our we may need to have our own set of normative values. But moving forward, we are hoping to change this now that there is an increasing prevalence of GERD. We have now more upper GI surgeons. We have surgical endoscopists and therapeutic endoscopists doing more and more anti-reflux procedures and POEM. We hope that a greater number of local hospitals will be able to perform these tests in the future, including our own. And in summary, pH impedance studies is the best available tool. So it's called the gold standard, but it's not a perfect test, but it's the best available tool we have for determining pathologic reflux. Esophageal manometry is the gold standard for assessing esophageal motility and used as an adjunct in GERD management to rule out other conditions such as achalasia. And lastly, the appropriate use and interpretation of these motility tests is guided by the Lyon Consensus for now and the Chicago classification. But as always, it should always go hand in hand with clinical judgment and experience. So thank you for your attention.
Thank you, Dr. Lawenko, for the very informative lecture. Our the next topic will detail the indications for surgical intervention for GERD. Several videos will also be presented on the different anti-reflux procedures currently employed. Our speaker received his training in general surgery from Quirino Memorial Medical Center and is currently a clinical fellow in minimal invasive surgery fellowship with the same institution. Our speaker is Dr. Johan Abraham Bagilat. Dr. Bagilat, can you start your presentation?
Thank you, sir. Good afternoon. I'll be reporting on laparoscopic treatment of GERD, the indications, and the technical considerations. From a surgical perspective, GERD is the failure of the anti-reflux barrier, allowing abnormal reflux of gastric contents into the esophagus. It is a mechanical disorder caused by a number of diseases like hiatal hernia, achalasia, esophageal spasm, ulcer, gastritis, even coronary artery disease, among others. Diagnosing and defining GERD is done by measuring the pathophysiologic abnormalities of the disease. So preoperative workup usually include upper endoscopy, 24-hour pH monitoring, high-resolution manometry, and assessment of the esophageal length using contrast studies and endoscopic findings together. The indications for surgery are GERD symptoms that have been severe and unresponsive to medical treatment associated with conditions like high volume reflux, erosive esophagitis, benign strictures, Barrett's esophagus, atypical or respiratory symptoms, non-compliance with medical therapy, and risk factors that predict poor response to medical treatment like nocturnal reflux, structurally deficient LES, mixed reflux, or mucosal injury at presentation. Laparoscopic fundoplication is the gold standard surgical treatment for moderate to severe GERD. The selection of partial or complete fundoplication is based upon the assessment of esophageal contractility and the presence of dysphagia. There have been many studies comparing Nissen with toupee fundoplication, mostly showing a higher incidence of post-op dysphagia for Nissen complete fundoplication. Hence, some would prefer Nissen fundoplication for patients with normal motility, whereas for patients with decreased motility and dysphagia, there's a preference for a partial fundoplication. Still, current evidence comparing Nissen with toupee show equivalent control of GERD and could result in similar prevalence of patient satisfaction. Having said that, I will now present the surgical technique for laparoscopic toupee fundoplication, then show some short clips of the Nissen and the door procedure. There are other anti-reflux procedures, but we don't have much clinical experience on these. So this is the usual operative setup, with the surgeon in between the patient's legs in semi-lithotomy, allowing right and left hand instruments to approach the hiatus with appropriate angulation and exposure. The patient is in a 30 to 45 degree reverse Trendelenburg to allow displacement of transverse colon and the small bowels. The camera port is placed above the umbilicus, about 1/3 the distance between the umbilicus and the xiphoid process, 2 to 3 inches left of the midline. The right operating port is placed 2 to 3 inches at the left subcostal along the midclavicular line, while the left operating port is 2 to 3 inches at the right subcostal along the midclavicular line. This allows triangulation between your camera and the two instruments. One lateral port for the retraction is placed at the left subcostal anterior axillary line. And your liver retractor is placed through an epigastric incision left of the falciform ligament. The critical elements of fundoplication include crural dissection and identification of your vagus nerves, fundic mobilization, circumferential dissection of the esophagus, crural closure, and the creation of a loose fundoplication by enveloping the anterior and posterior wall of your fundus around the lower esophagus. Once your ports are placed, anterior retraction of the left lobe of your liver is done, exposing your esophageal hiatus and the stomach. The surgeon proceeds with fundic mobilization, which will allow a tension-free fundoplication later. The gastrosplenic ligament is divided along the upper 1/3 of the greater curvature. And this is the division of your short gastric vessels. And this is extended to the posterior attachments of the upper stomach and continues up to the left crus. By retracting your esophagus to the right, the left crus is dissected and identified. Now the hepatogastric ligament is incised to expose the lesser sac, caudate lobe, and the right crus. The right crus is then dissected anterior to posterior. From here, lateral. This is your right crus being identified. And from here, lateral and inferior dissection of the esophagus is done with identification and preservation of the posterior vagus. Anterior dissection at the level of the phrenoesophageal ligament is done, avoiding injury to the phrenic artery and vein, which courses anterior to the hiatus. The left anterior vagus nerve beneath the ligament is identified and preserved. Now, the surgeon continues the circumferential dissection of your distal esophagus. by careful dissection of the lateral, posterior, and anterior soft tissues within the hiatus and into the mediastinum, with the purpose of bringing about 3 to 4 centimeters of esophagus into the abdomen. Now the crural junction is clear. Surgeon can now proceed with the crural closure using O non-absorbable interrupted sutures. The number of sutures will depend on the size of the hiatal opening. For the last step, the fundoplication, the posterior fundus is grasped and passed into the right, posterior to the esophagus, to position the proper portion of the fundus behind the esophagus. This is done using the shoe shine maneuver with the stomach behind the esophagus. And using 2O non-absorbable interrupted sutures, the posterior fundus is approximated to your right anterior esophagus, taking care not to damage the anterior vagus. And the suture is added to fix the posterior fundus to the right crus. Next, your anterior fundus is approximated to your left anterior esophagus. And usually 3 interrupted sutures are used on each side, creating a 270-degree posterior partial wrap. And finally, the suture is added to fix the anterior fundus posteriorly and high up the left crus. This allows recreation and reconstruction of the angle of his. That's the bougie being passed to show patency. And again, your hiatal repair and your posterior fundal wrap. So that's the toupee fundoplication. For the Nissen fundoplication, the first steps of the procedure are essentially the same, but the difference is in the creation of a 360-degree complete fundal wrap of the distal esophagus. And last, for the door fundoplication, the fundus is placed on the anterior portion of the esophagus, thereby encompassing about 180 degrees of the esophageal circumference. But this is usually done after a hemorrhaectomy for achalasia and not primarily for GERD alone. So these are my sources. And thank you.
Okay. Thank you, Dr. Bagilat. Um, our next speaker will be talking on the conundrum in reflux disease. Um, he received his basic and advanced surgical training from Tan Tock Seng Hospital and Singapore General Hospital in Singapore. Further underwent further training in advanced laparoscopic and robotic surgery with Seoul National University Hospital and Bandung Hospital in Korea. He is currently the head of upper GI and minimal access surgery unit of Mount Elizabeth Novena Hospital in Singapore. Our speaker is Dr. Jaideep Raj Rao. Dr. Rao, uh, you can start your presentation.
Thank you, Alambert. Let me try to share my screen. Is it okay?
Yes, we can see.
Okay, perfect. So good afternoon, everybody. And I would really like to thank Alan and the rest of your society for inviting me for this training program. It's truly a privilege to be a part of this, and the lectures so far have been, very stimulating. And in fact, I learned quite a lot also just, watching you guys. So I'm going to talk about reflux conundrum Alan asked me to speak about. As you all know that GERD is increasing not only in the world, in Asia too, and the obesity epidemic is added to this woe. And most believe that GERD is a surgical condition. And now more and more number of surgeries are being performed for both GERD and hiatus hernia. What are the conundrums? And conundrum essentially means these problems because mainly some of the issues have been that even though GERD and hiatus hernias are a surgical problem, a lot of it is being treated by the medical people. There's a big psychological aspect of GERD involved, and it is quite a technical procedure. It's not technically challenging, but it is a mathematical procedure. And I'll tell you along the course, there are important points that will make your procedure a success or a failure. There's also a situation that we have not reached consensus in this procedure. For example, whether to put a mesh or no mesh, what kind of mesh, etc. Um, Also, whether we decide whether this is Tupe or Nissen, etc. Also, there is a high rate of failure. Even in the best of hands, there is about 10 to 15%, and normal rates are almost up to 20-25% in long-term issues. And for these failures, what are there revision surgeries? And these revision surgeries are complex, and we'll talk about this. And obesity and reflux surgery is another conundrum. What surgery to do for these people, and then surgery for Barrett. So I'll touch upon it. I'll move quickly through certain topics because they've all been covered so excellently by the previous speakers. And here is the evidence. We know that fundoplication results in significantly less acid exposure, less lower esophageal pressures compared with medical therapy. High level of evidence. Anti-reflux surgery is an effective treatment for typical symptoms of GERD. It's also an effective alternative to medical with good symptom control, and these can be achieved with partial symptom from PPI. And while atypical symptoms improve in majority, we have to still be careful that this can be some issues. The quality of life is improved compared to medical treatment in terms of GERD, but always be careful that the surgery has to be done correctly. Now, typical symptoms, as you all know, we spoke about it, that the majority of the patients after surgery, they have good resolution. What about atypical symptoms? The atypical symptoms improve, and when I mean atypical symptoms, these are like cough, hoarseness, pulmonary symptoms, things like even asthma. there's an improvement in 60 to 90% of the patients, those who have anti-reflux surgery. Cough cure rates are, more than 50%. Short-term improvements are almost 100%, and long-term it can last to 70%. So 20 to 30 may get it back, and we'll discuss about this again in the future. So what are the predictors of outcome? Poor compliance, poor response to preoperative PPI. It's another very fascinating, because those who actually respond well to PPI also respond well to surgery. Those who don't respond may not respond well to surgery. So it's another something that you have to consider and test really careful before we undergo surgery for these patients. Of course, age should not be considered a contraindication, as similar outcomes for younger as well as older patients. And of course, care to minimize early post-operative things like gagging, retching, vomiting, etc., that may lead to anatomical failures. Investigations, I'm not going to talk about it because covered fantastically by Rona. And what are the indications of fundoplication? Those patients who are unwilling for a long-term PPI. Those people are on PPI, but they have side effects of PPI. Those that don't respond to PPI. Again, this you have to be very careful, because as I said before, sometimes if they don't respond to PPI, they may not respond. But of course, if you look and say whether these are anatomical problems, then this can be treated with a fundoplication. Of course, with severe esophagitis, strictures, etc., Barrett's, large hiatus, hernias. Control of symptoms occurs very well, 80-90% with Nissens. So the aim of the surgery is, of course, to restore a normal physiological situation, especially the lower esophageal sphincter, get a good intra-abdominal esophagus. Now, the learning curve, and a lot of issues have been because people doing upper GI surgery. This surgery, as I said, is very mathematical. And if you don't follow these certain principles, your surgery will be not successful. And this has resulted in, people going back to medicines, etc. And reoperative surgeries, of course, should be undertaken in high volume centers by experienced anti-reflux surgeons. So a learning curve for a procedure can be evaluated by operative times, but of course, it's for the rate of conversions and complications. So it starts off with a slow beginning. You have a steep acceleration phase, and then it plateaus once you become an expert. You have an early stage, which is a cognitive verbal stage. You break down this procedure into a complex procedure is a number of simple steps that make it complex. So you break it down to small steps and you master individual step. That becomes a cognitive verbal stage. Then you associate this finally until it becomes autonomous. And this is a journey from a beginner to an expert, where you initially have the knowledge, you comprehend it, you apply it, analyze it, evaluate until you become an expert. And the principles involve expertise, having the volume, and mainly standardizing this procedure so that it becomes more reproducible. So in our university, what I used to teach my residents and fellows was to break it down, and what I tell them is the 7 habits of a highly effective fundoplication. So we break it down. So habit 1 is dissection of the posterior mediastinum. And it's important to get this esophagus have at least 3 to 5 centimeters of the esophagus within the abdominal cavity. And a lot of the times, because of the reflux, because it's chronic, the esophagus shortens and it goes into the thorax. You have a short segment, and this is a problem. And you need to mobilize this esophagus well into the thorax, as you saw from the previous video. The habit 2 is preserving both the vagi. It's important to preserve both the anterior and posterior vagus and prevent injury to this. And you have to keep in that one plane just outside of it. The third habit is the transaction of short gastric vessels. And this will help in a good fundoplication, especially to create a Nissen, a floppy Nissen. What you want is a floppy Nissen. A lot of people says, well, you can do it without doing it. That's what I've noticed is only in viscerotropic individuals with a very, very floppy hiatus. I wouldn't recommend, I would always recommend to actually, take down the upper short gastrics so that you have a good, basically, and especially if you're doing a Nissen, you may get away with a toupee or, anterior if you have, floppy fundus without taking down short gastrics, but this is a good habit to do. Habit 4 is approximation of the right and left pillars of the crura. And it's important because this one will prevent the herniation of your wrap. Okay. And it is important, and I'll show you in the video, there's a peritoneum lining over this cruise. And it's important to maintain that because this is going to unite later and will, reinforce your cruise. If your muscle is, butchered while you're dissecting, then it's going to make it very difficult for it to heal and cause failure. The fifth habit is to have always create your wrap over a bougie. Even if you're experienced, make sure to have this bougie because sometimes the angle may change and you may narrow it, and it's a common cause of post-operative dysphagia. I noticed in that video that the bougie was put after the wrap was done, but I would recommend always that you put the bougie and do that wrap over the bougie. The sixth habit is to decide the choice of wrap. And you have your Nissen, you have toupee, and you have doors. Doors, we usually reserve it for achalasia. And you have a lot of studies, there's a meta-analysis, etc., that shows basically all these three are good if it is done correctly. If it is done incorrectly, the Nissen has the worst outcome. But if it's done correctly, it is actually the best procedure out of all. So it is the most difficult to do, and therefore it's the best, but it's also very unforgiving because if you don't do it correctly, you have more side effects. So older patients with a little bit of esophageal dysmotility, toupee or doors may be a better, a procedure because less chance of dysphagia, etc. And the last habit is the choice of a correct wrap. For example, doing the shoe shine maneuver, and you saw that in that video. And it's important to get that first bite of your correctly if you're doing a Nissen. Basically, you have to have the fundus, esophagus and fundus. Again, I'll show it in a video to prevent the stomach from herniating within itself and causing a type 2 or type 3 relapse. If you do it too short, then it's not going to work. If you're going to do it too long, it's going to cause dysphagia. So again, the length of the wrap should be adequate. So I'll quickly show you this video. I'm going to try to see how, sorry, we can go about this. Give me a sec. And can you see the video now? Can you all see the video?
No video.
No. You
Okay,
have to stop sharing, Jaydeep. You have to stop sharing the PowerPoint and share the video, I think.
Okay, hang on. So I'm going to new share.
You need to unshare. There you are. Perfect.
Yeah.
And then you share the video.
Now you can see that?
Yeah, we can.
Yes.
Yes, we
Can
can
you
see.
see the video now?
Yeah.
The video is okay, right?
Not
It's not playing.
Dr. Rao, press again the share screen and look for the program that's playing your lap Nielsen.
Okay. Okay?
Yes.
There.
Yes.
Okay, perfect. Okay, so here's what we're gonna dissect. Started usually with the pars flaccida, and you can see the right cruise there, and we're gonna dissect the right cruise. And I'm showing you this area. So you dissect the right cruise, and you can see. Hey, sorry. We go across. And you can see this peritoneal lining that is maintained over the cruise, and you should maintain that because that will help you to have a good, after you reinforce it, it actually maintains it pretty well. We go all around. And then the short gastric takedown. We join it back on the right cruise. And do the intrathoracic mobilization of the esophagus. And this can be variable depending on the size and depending on the length of the esophagus. And you can see here, you can see the vagus. And then we're going to repair the crura over the bougie. Now, after you repair the crura, there's always an issue of whether we're going to put a mesh or not a mesh, and I'm going to talk about it in a while. If it is usually the hernia is more than 3 to 5 centimeters, then I will put a mesh. But when you're putting the mesh, it should not be encircling the esophagus. The mesh should be there only to reinforce the crura. And usually you can just put 3 stitches, one here. Please don't do this. Even though it's the video is showing tacking, but I would recommend you not to tack, because there have been incidences where they've tacked in the wrong place, for example the heart, and it's causing problems. So we were just testing out the new tacker from Covidien, which can actually articulate. So please don't try this at home, as the Wrestling Federation says. And now you have this, 3 to 5 centimeters of the esophagus. Okay, so don't do this tacking. Because you could injure the aorta, you could puncture it. So after you do that, you pull your esophagus and you do the shoe shine. And you take the fundus, and the bite should be fundus, esophagus, fundus. A lot of people just take the stomach over the stomach, and this can cause the stomach to herniate out later. So this stitch will prevent your stomach from herniating or intussuscepting, causing a type 3 recurrence. So the first should be taken fundus, esophagus, fundus. Okay. And your Nissen should be floppy. It shouldn't be too tight. It's over a bougie. You put it, and you see after that, you should be able to pass your instrument underneath it. See, you can pass your instrument. So it's very floppy. So this is not going to cause dysphagia. And you can see that there's about 3 to 4 centimeters of intra-abdominal esophagus. You can either fix the wrap to the crura, or you can fix the esophagus to the crura. So, I learned this from this Aussie surgeon, and he fixes the crura, and I've been doing this, and it is given pretty good results. So just 1 or 2 stitches to keep the esophagus with the crura, and this is how it should face slightly towards the right. If it faces too much or to the right or to the left, it could cause torsion, right? So I'm going to get out of this screen share and get back. How do I screen share now? Oh, share screen. Okay. It's all right?
Yeah.
Okay, so I think I have one more with the biological mesh, but we won't go because of time, because I have some other videos. So again, too tight a wrap, too long a wrap, and lateral torsion. These are the three things that can go wrong. So keep that in mind while doing it. Prevention of wrap migration: anchor the esophagus to the cruise, or you can anchor the wrap to the cruise. You can decide how you want this to happen. uh, so crural closure and mesh reinforcement. So crural closure is strongly recommended. Mesh reinforcement may be beneficial, uh, and we'll talk about it. So the important thing about the mesh is a lot of historical data, because the mesh, they cover the entire esophagus. It used to stricture and cause dysphagia, etc. And there's also problem of mesh erosion. So this should only reinforce the hiatus if you're putting a mesh, usually for defects more than 3 to 5 centimeter, or if the poor hiatal pillars are there, or if it's a redo surgery. These meshes, PTFE, are not recommended nowadays, and these U-shaped meshes or the heart-shaped meshes that you saw, composite meshes, are recommended. Now, this is a study that compared mesh versus no mesh, good studies, and you can see that the recurrence rates were much lower in those who didn't, those who put reinforced with mesh rather than without mesh, and mesh related complications were extremely low. So this was a survey from the SAGES members of the various types of mesh: polypropylene, composite, biomeshes, and more than 5,000 patients survey. And you can see, of course, that the failure rates were slightly higher in biomaterials because they were absorbable, but of course the lowest complications such as stricture and erosion rates. And the conclusion from this was that the use of mesh actually decreased recurrent rates, but what type of mesh they put didn't matter so much. So long as you put a composite mesh, you're just reinforcing it, then you should be okay for large. So what about failed treatment? Usually it is due to a wrong indication. They've not been worked up properly. A lot of it is from technical failures because the operation has not been done correctly. And of course, there's a lot of anatomical failures, etc., that can problem. Again, investigation should be thoroughly investigated for recurrence, and you should go through all these things again, the lecture from Rona, before considering any reoperation. How do you test for your endoscopic evaluation of your fundoplication? There are some criteria. You can see that the lip, it should be thin, the body should be about 3 to 4 centimeters, the anterior groove should be shallow, the posterior groove should be deep, and it should be tightly fitting the scope, and it should move during all phases of respiration, etc. So this is an example of a good fundoplication when you see it under an endoscope. You have anatomical failures. This is type 1A, when both the GJ and the wrap are above the diaphragm. Type 1B, where GJ is located below, but whereas the CJ is above the diaphragm. Type 2, where the fundus of the stomach has moved along with the entire wrap. And type 3, where you've not taken that fundus, esophagus fundus, and therefore the stomach is intussuscepted through itself and caused a migration. So redo applications are complex, higher morbidity rates, longer hospital stay, associated with tiny mortality rates because of the complication, and success rate is about 70%. So it's best to do the best operation the first time, get it right, rather than having to go in again. Okay, so the Collis lengthening gastroplasty for shortened esophagus is very rare. If you basically mobilize the esophagus well, you hardly ever need to do this nowadays, and you'll be able to get away with your normal basically the fundoplications that we have. And esophagectomy is really the last resort that you have to do. What about Barrett's and anti-reflux surgery? It's issue. Please tell me if I'm going over time, and I will cut down. Um, and you already seen the strata procedure by the previous, so I'll won't say. Obesity with GERD deserves. Let me see. I think I've missed out one. Yeah, so I've missed out one slide, which is actually uh, for Barrett's. And if there is a high dysplasia, the issue is whether to resect, and what you can do. That slide is somehow not showing on this. And you could do basically a proximal gastrectomy with a jejunal interposition. Do I have time to show a video of that? So maybe I'll show you a video of that later. The other important issue is obesity and GERD. And this is high failure rates in morbid obesity. And it's because you're unable to do the fundoplication properly. And if obesity is related with GERD, then the procedure of choice would be a Roux-en-Y gastric bypass. Those who have undergone sleeve gastrectomy also have a higher prevalence rate of GERD, and it can range up to 20%. And you should always counsel your patients who undergo sleeve that this GERD can worsen. If you look at this systematic review, you can see that 15 studies, 4 studies show that there's an increase in GERD after sleeve. However, a lot of studies have also found that sleeves GERDs have decreased after sleeve because of weight loss, etc. And surgery for GERD after sleeve should be the last option after extensive workup. So what you can do also nowadays to prevent this is what we call as a Nissen sleeve. You can add a sleeve gastrectomy to your Nissen, and I will show you a video. You can't see the video, right? Again, I'm going to new share. Can you see the video now?
Yes.
Okay.
You can see the video.
Okay. So this is, it starts off with a typical Nissen fundoplication. So basically you mobilize the hiatus. Mobilize the esophagus on all sides. And after you mobilize the esophagus, you repair the make sure it's completely mobilized. And then you divide the entire length of the greater curve as if you're doing the sleeve. All the way up to the left cruise. Then we close the crura. And it's important here again to pass the bougie before you do the fundoplication. Okay, now we're going to do the fundoplication over the bougie. And then we're going to do the, fix it, the fundoplication to the cruise. And then we're going to pass the bougie still further, and we're going to do the sleeve gastrectomy. So it's important in this sleeve gastrectomy that you don't go straight all the way to the area of fundoplication. We stop where the fundoplication has already occurred. You don't want that because that area has got 4 layers of stomach around it, and you don't want to go there. A lot of the initial reports of this procedure failing was because they went all the way up to where the fundoplication occurred, and it was so thick that the staple malfunctioned and there was perforations. So you stay just where the fundoplication begins. So this is called a Nissen sleeve, and I'm gonna come back. Okay, and this was propagated by David Noka, and he had pretty decent results for treating. Re-sleeve is only if the first sleeve is not done properly and it distends, so I won't talk about it. The other option is a ligamentum teres cardiopexy. So if you've done a sleeve and they have reflux, you close the crura and you bring the ligamentum teres and wrap it around the CEJ and fix it. And how this helps is that when you breathe, the liver goes down and it actually pulls the CEJ and maintains it intra-abdominally during your respiration. Again, this is, even though some series are there, there's not a high level of evidence. Dr. C.K. Huang has got some experience in this, but it's still at an early stage, and we need more evidence before we use this procedure. The new kid in the block is called LINX. It is a magnetic sphincter augmentation. And what this does is it's a series of beads which is fixed by a thread, and it's a magnet. So basically, by an elastic thread. So basically, when you swallow, these magnets open up and allows the food bolus to go through, and then the magnet brings the beads together, so it maintains the sphincter. So this is the safety analysis of the first 1,000 patients, and you can see that it has got a good safety efficacy and good results with the erosion rate of 0.1%. So when you look at even the side effects, they're actually much low compared with baseline 5-year follow-up of LINX procedure, and erosion rates are also pretty low. But again, these are done only in select centers under supervision, and we've just started doing this in Singapore. We need to wait for long-term results before whether we brand this for primary reflux or for treatment of reflux after sleeve, or we need to add this with a sleeve in case we still need to do trials. So this should be done under a trial basis. Again, this study looked at comparison of relief from symptoms, impedance, GERD questionnaires after, and Demister scores, and the LINX procedure did very well compared to daily dose of PPI. So in conclusion, I'm just going to go, before concluding, maybe I'll quickly show you this video. Let me go to... So this is for Barrett's with high-grade dysplasia or carcinoma in situ. If you want to treat, because total gastrectomy for this is usually very morbid. Ivor Lewis is again morbid. This is what we do, a proximal gastrectomy, but we do with a jejunal interposition. So we dissect at the hiatus as usual. We mobilize the short gastric. And then we take down the left gastric artery. This is the D1 plus dissection, because this is for high-grade dysplasia. It's almost like a carcinoma in situ. And there's a left gastric being taken down. and there's some lymph node dissection there. I'm just going to keep that. Then we divide the esophagus. And then we make the stomach pouch. So we're doing a proximal gastrectomy. So we have removed the Barrett's section. And now what we're going to do, we're going to bring the loop up to do an esophagojejunostomy. And then I do this hand-sewn anastomosis, esophagojejunostomy, using a V-lock. The posterior layer followed by the anterior layer. And then I'm going to fix that. So now what we're going to do is we're going to keep this as a jejunal loop. So 15 centimeters down the jejunal loop, we're going to do a side-to-side gastrojejunostomy. So the food is going to come from the esophagus into this jejunal loop, and then it's going to go into the stomach. 3/4 of it is going to go into the stomach. 1/4 will still come down the jejunum. But this will prevent reflux of stomach contents into the esophagus, because you don't want to do a proximal gastrectomy which has got a high rate of reflux. We're going to divide that loop, and then we're going to do a jejunostomy. So this is reserved for either early tumors of the CEJ or Barrett's with high-grade dysplasia. This is an option for you to do what is called as proximal gastrectomy with jejunal interposition and double tract reconstruction. So I'm going to screen. So this is my final slide. So laparoscopic anti-reflux is very effective and has long-lasting treatment. It is important to carefully select the patient through proper preoperative evaluation. Technical elements are very important, and managing reflux after fundo application can be challenging, must be managed in high volume centers. Thank you very much.
Kasi yung speaker natin yung maingay sa...
Thank you, Dr. Rao, for your informative lecture. Our next topic will be on the speaker sharing his experience in the surgical intervention for hiatal hernias and GERD, after which will be followed by a bonus video presentation. So our next speaker is a member of multiple international surgical societies. He is currently the regional coordinator of ACOI. It's an Italian Association of Hospital Surgeons. He is also currently a consultant with the Division of Surgery at St. Chiara Hospital in Trento, Italy. Our next speaker is Dr. Alessandro Carrera. Dr. Carrera, you ready to?
Yeah, yeah, I'm ready. Hello to you all. I hope you can hear me. And of course, I hope you can see me. You should have my video downloaded on your station over there. So maybe it's better if you can start the video from your computer. You should have the download. I sent it by email this morning by WeTransfer. Can you play the video?
They are setting it up.
Okay, sir.
Okay.
Oh, nice.
Video playing.
So this is a laparoscopic hypoplasty with fundoplication. As you see here, the patient positioning is quite similar to a laparoscopic cholecystectomy. The first operator is between the legs of the patient and the two assistants on both sides. And this is our trocar positioning. The laparoscope is 3 fingers above the umbilicus. So we start reducing the gastric fundus in the abdominal cavity. This was a large hiatal hernia. The left gastric vessels are pretty evident here. And we found a hirtal artery, which is a left accessory hepatic artery here. So we decided to preserve it. So the first step of the intervention, as we saw in the previous videos, excellent previous videos, is the dissection of the lesser omentum, exposing the right crust. We use a ligature to do this time, but it's a good idea also to use the arthroscesium or something similar. This is our energy device. It's very good for this time. So we proceed with this dissection. As I told you, preserving the hirtal artery. Okay. So proceeding with the following step, we dissect close to the right crust and proceeding upward along the crura. Now we have, you see the right crust on the left here. The video is not so fluid looking it from here. I hope it's better in your view. So we proceed by the dissection along the crura and giving some traction to the stomachus. We can expose even the phrenogastric ligament. So we are now proceeding with the dissection, exposing the left crust. Now we are completing this time. The left crust is pretty evident here. Nice. Now we are going below the lower esophagus, entering in the mediastinum. And here we can see the vagus nerve, the anterior vagus nerve. So now we can pass silicone string around the cardias to give some traction, helping in the following step. Because we have to dissect all the attachments between the lower esophagus and the lower mediastinum in order to release and expose 2 or 3 centimeters of the lower esophagus. So we can continue using our energy device to make this step, obviously being very careful in avoiding damages to the esophagus and to the mediastinal structures. We are now finishing this step, exposing all the crura. Now we can grasp the anterior gastric wall and making the Shushan maneuver, preparing for the fundoplication. As I will show you later, we didn't divide the short gastric vessel because we preferred in this case to make a Nissen-Rossetti procedure. I will talk about it a bit later. It's important now to insert a probe in the esophagus, a 42 French probe, to calibrate the hyatoplasty. As you see here, we use 3 stitches in non-resorbable material. It was about 4 to 5 centimeters wide defect. So in this case, it's important to use a mesh to reinforce the hyatoplasty in order to avoid recurrence. So we are now ready to proceed with the mesh, as you see here. We decided to use a synthetic mesh. I personally believe that biosynthetic probably is the future. It's a very nice material. I like it very much. But in larger defects, probably it's better to still use synthetic meshes. So this is a heart-shaped mesh. We fixed with 2 sutures on both sides. One between the mesh and the right crust, and another one between the mesh and the left crust. Okay, now we are on the other side, completing the second suture. And finally, a last stitch can be used to fix the tip of the mesh. Okay, just to avoid the migration of the mesh. So now we can go on. The mesh is well fixed. And as I told you, this is the difference between the floppy Nissen and the Nissen-Rossetti. We do not dissect, in this case, the short gastric vessels, and we grasp the anterior gastric wall, making the wrap around the esophagus. We have similar results between these 2 procedures in long-term outcomes, but in short-term outcomes, the Nissen-Rossetti has better results. Obviously, we should have a tension-free wrap. In case it wasn't possible to make a tension-free wrap, it's important to make a floppy Nissen procedure, so to divide the short gastric vessels. How how we perform the fundoplication simply with 3 not resolvable stitches. Obviously, the probe is inside the esophagus. I perfectly agree with Jadip. With these stitches, we should pass even through the esophageal wall in order to prevent the complication that Jadip perfectly explained us. So now I finished my video showing you the final result with a contrast X-ray. You see the contrast flow passing through the esophagus without any problem. So I finished now. Thank you very much. And I'm here for any question.
Thank you, Dr. Carrara. We'll reserve the questions for the open forum after all the lectures has been presented. The next would be a bonus video presentation by Dr. Sarfaraz Baig. He's an active member of multiple international surgical societies, a well-known surgeon in GI, MIS, and bariatric surgeries. He's currently the director of digestive surgery at the Bellevue Clinic in Kolkata, India. Our speaker, Dr. Sarfaraz Baig.
Hi.
Sure.
So thank you very much, Alambut, for this introduction. So if you can hear me properly, I'll just take you through a video. Let me first see if we can share the PowerPoint presentation here. Yeah. Hello. Hello. Can you all hear me? I can hear some voices from somewhere else. Okay. All right. So this is what I wanted to present today. I think everybody is presented so very well. The only video that I think may add some value to this entire half day's course is that we can talk about RAP migration after Nissen's fundoplication. And this is something that may happen in about 10% of cases in some series. Therefore, it's important to note what are the mistakes that we may not do and how to deal with it if it is present. As Jaydeep said, this should be done in a tertiary center only. Now, we can see here that this is a patient. I've just put in one sagittal section because I don't want to put in a video of the CT scan. But can you see that there was one entire wrap gone into the chest? And if you look at this particular video, this is the first video. This is the first video where the fundoplication was done. And can you see that the esophagus has not been dissected? The phrenoesophageal ligament is not dissected, and the fundus, esophagus fundus, is basically fundus, stomach, and fundus. Hence, these wraps are prone to migration. So this is the first video of the patient which we could find out, and you can see that the mistake being done here, although everything is fine, that the phrenoesophageal ligament anteriorly has not been done properly. I must ask Alambut, is the video playing properly? Otherwise, I will have to exit and play the video from the main.
Yes, it's playing properly.
It's playing properly. Thank you so much. Then I can just continue with this. So I would like to show, 1 second. Yeah. So this is the video of how we corrected this. Now, when you go back inside, what we saw after putting in the retractor was that the fundus, you see that the stomach has gone into the hiatus and stuck there. First trick in tertiary cases, first trick in these redo cases where the fundoplication has been done, go from the left. Go from the left because left would be a virgin area, less chances of traumatizing it. That's the first trick that I want to add here. And identify the left cruise. So we would like to identify the left cruises, any of these RAP migrations that we see and we are operating. So you can see here, as soon as we go up at the top, I will take a hook, because taking a hook at this area will make me use a cutting cautery and not traumatize the fundus here. So the third thing that we do is we do the division of anterior phrenoesophageal ligament. So is the video playing properly? I'm asking again, Alembert. I'm sorry for that.
Yes, it's playing properly.
Okay, so the phrenoesophageal ligament, when it's cut, you can see that the stomach has gone in. And here we stop and reassess ourselves to be sure that we are not cutting through the stomach. The fourth thing to do is reduce the wrap into the abdominal cavity. Again, we start only from the left. We are not doing anything from the right. And I'm using a suction here, which acts like my finger. I'm trying to bring as much as stomach, the wrap which has gone inside. So we have converted a type 1 hernia into a type 3 hernia, mixed hernia. The G junction and the fundus have all gone inside the chest. So what we're trying to do here is we're trying to dissect from the left side, pushing the pleura away with the suction cannula and then using an energy source. After we do that, we make a window from the right to the left. Now that the left dissection has been done, and with a gauge piece, we use it like a stirrup of a horse. And now we do a posterior dissection. If you can see, this is what we are doing, that the posterior dissection is now being done and we are proceeding towards the thorax. Next, we use a suction and make a U-shaped movement from the right to the left. And that is what we've learned from Dr. Parks. And once we do that, we take away all the tissues from the close to the esophagus away. And by keeping close to the esophagus, we avoid damaging any structures in the mediastinum, including the pleura. Then the difficult part, taking down the wrap, undoing the wrap. So first we try to make a window. Once we do that, we take a cutting cautery on the hook and we come in between. Sometimes we have used a stapler in this occasion, but if we can manage doing this, is better. You can see that we can see those ethibond sutures of the previous surgery. Now, once we do this, we can see the esophagus. Once the wrap is undone, we can see the esophagus. What else are we doing? We take a scissor to take away the final pieces of tissue of the wrap. And once we do that, we can splay the entire fundus of the stomach straight. So what we do is we can undo the entire wrap with some understanding of where the anatomy is. You can see these the greater curve now appearing. Once this is done, we have to do a refundoplication, right? We have to redo this entire thing. So we do the shoe shine. We look at the esophagus is now 5 centimeters inside the abdomen. We know the shoe shine has been done. It is completely okay. It's going to stay in that position. Now we do a cruroplasty with ethibond sutures. We try to avoid putting in mesh in our hiatal repair. Although we are waking up to the idea of using meshes, we still use it only when once we are sure that we need to use it. In this case, for example, we are happy because this cruise is coming easily together. Once we see that as happening, what we do is we take we do the fundoplication on it. You can see that these tissues don't look good, and the reason is because once you've undone the wrap, they look pretty ugly. So here we are doing fundus, esophagus, fundus sutures. Again, ethibond sutures are being used. It's a Nissen in this patient, and because this patient had a wrap migration and heartburn and reflux, we try to do a complete fundoplication instead of partial in this patient. Once that is done, we sometimes like to put in a stitch of this wrap with the right cruise, sometimes not. There have been some criticism that if you put a mobile structure like this onto the cruise, they may interfere with the deglutition process. So this is how it looks to us. You can see that this now looks okay. This is a loose floppy wrap. The hiatus has been, cruise has been repaired well, and this looks okay. This patient is under a follow-up of about 18 months now. And a follow-up map patient for academic purposes to be sure that we are not missing anything in this patient, and she's done well. So I will just leave you with this thought that with RAP migration, we have learned, what we have learned is that some patients, like we were used to do, where we used to do in these patients crural repair. Now we have stopped doing only crural repair for this patient, but applying mesh. But that exactly is not my yeah. So what I would like to do, send signals from my very small videos. A, RAP migration happens because if we are not using mesh in large hiatus hernia, A, and two, more importantly, if the dissection is not adequate, if the esophagus has not been brought down, and if we are taking stitches fundus, stomach fundus, not dissecting the antephrenosophageal membrane, then the RAP migration will be higher. And if there is a RAP migration, A, you may not do something. We may just observe this patient. It's not necessary to operate all patients, but if they have dysphagia, they have the heartburn and regurgitation, then we need to operate. Do operate only if you have done enough of these cases yourself. And once we are doing these cases, it's important to follow certain principles. Start from the left side, identify the left cruise, divide the antephrenosophageal membrane, dissect the esophagus and pull all the fundus back into the chest from the left side first, make a window from the right to left, then do the right-sided esophageal dissection and bring the esophagus down. Once it is done, undo the wrap with a cutting diathermy or a stapler or scissors, and then do a fresh fundoplication after doing a cruroplasty. If during cruroplasty you want to put in a mesh, you can put in a mesh. Finally, do the fundoplication, make it a loose wrap, and if need be, suture the wrap to the right cruise or to the diaphragm. Thank you very much.
Thank you, Dr. Baig, for that very impressive video.
Thank you.
I would like to open the session for open forum. There were several questions raised initially. I don't know if I think they have been answered. Are there any other questions for our panelists, our speakers? Oh, okay. I guess this would be directed for Dr. Lawenko. Which hospitals in the Philippines have manometry testing and pH studies?
Sir, at the moment, only one institution, St. Luke's Medical Center at QC. Global has one, but I think their machine is in repair. So at the moment, it's just Quezon City, St. Luke's. I don't know if Cardinal, Dr. Buenafe, will be acquiring one.
Yeah, we are in the process of getting the HRM, and the one who's gonna be our expert on the HRM machine is, again, Dr. Rona Lowenko. So that's why we invited Rona. We'll be having one in Rizal as our charity HRM unit, and Cardinal as our private HRM unit.
Okay, sir.
Any other questions?
Alimbert?
Sir?
Dr. Sarmiento here. Just a few questions to all the speakers.
Okay, sir, go ahead.
Okay. Okay. I'd just like to go. What piques my interest is the revisional post Nissen fundoplication surgeries, and sometimes these patients would actually there are a lot of there'll be a lot of Nissen fundoplications done in the country, and as mentioned, as we have seen, most of them are done without even a boogie inside the esophagus where when once they do the wrap, and most of them would come back, and the referral to our service, the endoscopy service, is actually dilatation of that. They complain of dysphagia, and they would refer these patients for dilatation of that pseudoachalasia or this iatrogenic achalasia. But the problem is, by experience, the dilatation will not work, and we will all go for revisional surgery. And what has worked for us is we do revision and we do to pay instead of the Nissen fundoplication. So what are your thoughts about, instead of doing as I showed earlier, the repair is again a Nissen. What are your thoughts about doing a revision, just doing a toupee versus a Nissen fundoplication? Because one of the problems we have here in the country, as mentioned, is there's only one center that does the manometry, and most of the upper GI surgeries that needs manometry or pH testing here are not actually being tested with manometry or with pH monitoring.
Yeah, so can I take that question, Dr. Alambat?
Yes.
Sure.
Yeah, so I think the question is very well raised. Depends on why you are doing the revision. So if your revision is because the patient RAP has migrated, where the reflux and heartburn has happened, is again, then choosing between Nissen and toupee will depend on whether there is a residual dysphagia also or not. So in my patient, there was no dysphagia. Hence, I was not hesitant to use a Nissen. However, when you say that the patient has a revision because there's dysphagia, it is obvious that you would not go back and do a Nissen. Probably you'll do a partial fundoplication, in which case toupee is perfectly justified. So doing revision, the indication will matter a lot. And I would definitely like to inject, and I think Dr. Rana is going to agree with me, that a manometry is of immense importance in understanding what kind of fundoplication we can put in place. So with the manometry, we have a huge help, and I'm sure with centers getting more and more manometries and with trained people explaining to us about manometries, we'll also learn where to use what kind of fundoplication. I hope that answers your question.
Can I have a question?
Yeah.
This question goes to my very good friend Sarfaras, Jai, and of course Alessandro. I had this patient actually, where I did a laparoscopic fundoplication. We did a floppy Nissen on this patient more than 2 years ago. And then suddenly patient had a difficulty of breathing after a bout of drinking, and then a sudden feeling of coughing. True enough, I asked the patient to go to a emergency room and had a chest X-ray and CT scan. True enough, there's a migration of that fundoplication at the chest wall. My question is, how many of you had an experience on a recurrence of your hernia more than 2 years or even more than a year after the repair? And what are the events that would predispose your patient to a recurrence? This guy, this patient is actually a young patient, lawyer at that, with no other symptoms, no pulmonary symptoms, just a sudden bout of retching. And what can you do after surgery to prevent such things?
Yeah, so if you are asking me, Alan, then my answer is that I've had one death because of RAP migration. One death. So This is again a young chap who had a fundoplication, and about 8 to 10 years later was in another city and presented there with sudden breathlessness. By the time he could reach the hospital, he was no more. So I am presenting this very extraordinary case with the idea that RAP migrations can be actually very dangerous. You know, when the RAP is huge and the esophagus is shortened, it can put pressure on the cardiac, lung status, and it may be happening over a period of time, decreasing the reserves, cardiac and pulmonary, over a period of time. So the patient can present with a sudden catastrophe. Also, aspiration pneumonia and sudden vomiting with aspirin pneumonia could take the life of the patient. It is important to remember that RAP migration does happen in a significant number of people, of our patients. First thing is to prevent. And that is why I brought this RAP migration video today, because the most important thing, as Jaideep said and all these speakers said, a nicely done fundoplication is very good. A badly done fundoplication is very poor compared to medical treatment. We cannot take this lightly. The video I showed you of the first case where the RAP migration happened, because the anterior phrenoesophageal ligament was not dissected and the stitches were fundus, stomach, and fundus, and therefore it migrated. It's a sock effect. So intrathoracic pressure pulls it up, and that is what happened, and that migration became bigger and bigger. There are other patients who may have asymptomatic RAP migration. Fortunately, many of the RAP migrations are asymptomatic. We don't have to do much about it. We can just wait and watch. We can do CT scans, endoscopies, manometry to be sure that we are not dealing with a time bomb. However, when the RAP migration is big, symptomatic, we need to do something about it and bring it back. So prevention is A1. 2, use of the mesh. So one is your anti-phrenoesophageal ligament must be dissected. Stitches must be in the proper plane, fundus, esophagus, fundus. Big hiatus should have a mesh augmentation according to recent evidence. So that is 3. And 4, follow-up, surveillance. So these are my 4 points to prevent RAP migration. If you do have, then asymptomatic, nothing, wait and watch. Big RAP migration, symptomatic, go back, do it again. Have a colleague to assist. I think that's my points. Those are my points.
Thank you, Sarfraz. Alessandro?
Listen, I perfectly agree with these concepts. I would just add a little element. Probably the migration happens sometimes for a bad indication, because probably in these cases, patient had a brachioesophagus, smaller esophagus. So must be studied carefully before the indication for surgery. Because if you really have a brachioesophagus, so this risk is very high and must be very careful in indicate this intervention for these patients.
Agreed.
Yeah, Jai?
So I agree with both, Sarfraz and Alessandro. Good points. Just to add on, so I agree. The important part is the migration usually occurs in large hernias where it's just been closed and not reinforced with the mesh. So mesh will definitely decrease that chance for large hernias. Fixing that, the Nissen fundo plicated stomach at the cruise or the esophagus or at the cruise will decrease the chance. Thirdly is your extubation should be quite smooth. They shouldn't be coughing and this, during the extubation, and the pre-operative, any factors that causing chronic cough should be alleviated. And lastly, the first few weeks are very important.
Yes.
And they should be given important diet. So usually what we do is 2 weeks after will be only liquid diet, then followed by 2 weeks of puree diet, then semi-solid diet, and then progress. So this prevents somebody from eating a large meal and then choking and then vomiting and retching and things like that. So they learn to really eat, and then strict diet this of eating in a very small amount. So just a fistful at a time, breaking your meals into small. So this will prevent, again, dysphagia, retching, vomiting, things getting stuck. And by then, everything is healed up well, and it prevents any, acute migration. Chronic migration, of course, is, different, Safra's already covered things like fundus to stomach to, without doing the esophagus. So.
Yeah, thank you. Actually, looking back on this patient, the 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 after the recurrence on this patient, it's I think more than 6 months now after the recurrence. And I was just looking at the patient. Looking back, we've done a lot of series for food duplications. We've done a lot, especially in our centers where our gastroenterologists would are really bent on referring patients for repair, and we've had a lot of cases like this one. Looking back, there's nothing peculiar on this patient. But the only, I think that the only very peculiar on this patient was the bout on retching right after a big drinking, big drinking session with his friends. And the surgery, I would always tell our fellows, the most important part in doing are the same, like Sarfraz pointers. But the most important part of that procedure is the lengthening of that esophagus. Once you lengthen that esophagus, at least 4, 5, 6 cms, I would go for a 6 centimeter intra-abdominal esophagus, would somehow have a good, you'll be able to make a good floppy Nissen on that area, and then attachment or fixing that funduplication at the crura of your patient. I think that's the more.
Yeah.
But looking back, I'm quite averse in placement of meshes after repair of the crura because of a lot of issues on mesh migration, injury of that esophageal junction where the mesh is attached near that esophagus. So these are the things that I'm trying to look at, and I try to shy away from placement of a mesh. But then again, like what everybody would say, for a huge hiatal hernia, sometimes I would put a mesh, but I put a mesh that's quite just straight one that would reinforce the posterior part of that crura. I would shy away from the wrap up, the wrapping around of the mesh, primarily because of the fear of mesh migration into that esophagus. But thank you very much for all your sharing your experience.
Okay, we see several people with raised hands. So allow me to recognize Dr. Michelle Lim Lu to ask her question. Are you there, Dr. Lim Lu? No?
Alem, I think
yes.
the participants they cannot share their audio. They can type the questions on the chat chat box.
For the attendees, can you enter your questions in the Q&A box or the chat box? Let me recognize Dr. Don Rosello.
Yeah, first of all, I would like to commend all the speakers for very good lectures and very nice videos, especially Jaideep with this 7 habits to follow. One habit that you might want to add is applying sutures between the crura and the esophagus. I think this would really help a lot because it would make sure that you have adequate length at all times of the esophagus within the intra-abdominal compartment. This could also be a problem with regards to Alan's question, because Alan mentioned having a migration. I think migrations happen in 3 occasions. One is the crural defect is so huge and it wasn't repaired properly, or a mesh is really necessary. Second is there is already shortening of the esophagus.
And sometimes we try to lengthen the esophagus, and we know we can dissect all the way to the left pulmonary vein. We pull it down, but then, we have adequate length, but then it creeps up again. Then that's the question, that we have to anchor the esophagus on the crura. That's one thing that I believe that we have to do. We have to anchor the esophagus on the crura. I think that's a very important step. And the third would be a technical. And we have to think that if the esophagus is too short, we might need to do a collis gastroplasty. If you remember, we need to do a collis gastroplasty to have a sufficient length of esophagus in the intra-abdominal cavity. And maybe one take-home message for the ones viewing this webinar is, first, I think a buji is really important when doing this fundoplication. Everybody would agree that buji is necessary, not unless you're an expert and you've done a lot, that you'd be comfortable doing these procedures without a buji. But I think a buji between 50 to 60 French, I usually use a 56 French buji for a Nissen fundoplication, would be ideal. And second is, everybody has to be very careful and really ask help when they're doing the procedures, for their first 15 or 20 procedures, because redo surgeries are very difficult. And I believe that these surgeries should be done once, and it should be done right. And thank you to all the speakers.
Okay, there's a question from Dr. Michelle Lim Lu. This is directed to Dr. Rao. Dr. Rao, how do you manage your laparoscopic sleeve gastrectomy patients with in vivo GERD unremitting with medications?
Yeah, so this is a very good question. And this occurs in about almost 15 to 20%, post GERD, as in the slides that I showed. So usually, again, we have to basically investigate them very thoroughly, endoscopy to see what is the grade of reflux, and then we have to start them on medications. So if the medications are not working, even after maximum, you've increased the dose to the maximum, and at least you've tried it for 6 months, because note that a lot of the time you may have reflux post-op, but these reflux will usually decrease at the end of 1 year after a sleeve, and usually by 2 years to 3 years it usually will remit. So persistent reflux after 2 years of sleeve, and it's intractable reflux affecting quality of life, then we have to consider surgical intervention. So one is, of course, you can try the endoscopic method, strata. You can do the other, the plicating it also can be tried. If that doesn't work, usually we would want to convert this to a Roux-en-Y gastric bypass. So these are some of the things that can be done. Nowadays, as I mentioned in my lecture, the new kid on the block is called the LYNX magnetic dynamic sphincter. So that is something, a simple intervention that can be done, but it needs laparoscope again. So you could just put that sphincter around the CJ to see the cause of reflux. But it's important to really investigate the reflux, make sure that there's no hiatus hernia that was missed first, or there's a development of hiatus hernia, because if that is there, then you can just repair the hiatus hernia. But if he's having really bad symptoms, then it's better to convert it into a Roux-en-Y gastric bypass.
Yeah, can I add something here, Jaideep? Yeah, so a lot of our patients who opted for sleeve instead of Roux-en-Y gastric bypass, even when they have a reflux about 2 years or 1 year down the line, they are very hesitant to undergo a gastric bypass. Some of them, they reject the idea because they've been probably sold to the idea that the sleeve is keeping the GI anatomy intact and they don't want to disrupt the GI anatomy. So LYNX is something that's not available in Calcutta, in our part of the country. So what we do is you use cardiopexy now. So I in fact had a video, but I thought for the benefit of time I did not. I still have it on my desktop. But a cardiopexy is something that we have been using. And what it does is it gives us an opportunity to dissect the hiatus, do the crural repair, bring the fundus back, and then use the crus like a lynx. It is like a lynx. So the ligamentum teres is taken around the G junction and wrapped on itself and then fixed to the right crus. So it acts like a lynx. It's tissue repair, and you also repaired the cruroplasty also you've added with it. So this is something that we've done, and I think it's appropriate to share it here. Thank you.
So, any other questions for our speakers and panelists?
Albert?
Yes, sir.
Since we're on the topic of links, I'd just like to add a few things with regards to the magnetic augmentation LES device. I worked 5 years ago as a developmental endoscopy unit fellow of Christopher Gastout in Mayo Clinic. And one of the projects that we had then was placing these magnetic links through a submucosal tunnel right around the G junction. But the experience was and these are animal studies, and the magnetic links would actually erode into the lumen of the GI tract of the porcine. And now there's a new fellow who was able to place these links or these magnetic beads to the adventitia. So aside from going through the submucosa, went through the muscle and placed that bead to the submucosa, and I think he has better results. The beads would stay inside the adventitia layer longer compared to just placing it submucosa. So just a piece of nice to know stuff with regards to links.
Well, actually, the links is you can actually just the tradition, the way it is just you place it around the stomach. I guess putting it in a layer, submucosal layer itself, will cause some sort of inflammation and fibrosis, and can increase the risk of this erosion and migration and stricture to occur. Whereas when you put it around, then it's supposedly less. But these are from select centers, LIPAMs and all that. We still need to wait for larger data, and at the end of it, of course, it's still a foreign body, and it has all the the effects of a foreign body, things like erosion, migration and stuff. It is supposed to be lower as the data that I showed you, but again, these are from very select centers, and we really need to be careful and evaluate it under supervision in a so-called trial basis before we give the final word on it.
Alambert, we can't hear you.
Any more questions or okay.
Sorry, gentlemen, I have a small emergency. I need to go to the hospital. So is it okay that I take leave?
Yes. Yes. Thank you, Dr. Rao, for joining us.
Thank you. Thank you so much, Alambert. Thank you, Alan. Thank you, Alessandro, Sarfraz. All great to see all of you. And hope to catch up with you guys soon.
Thank you, Jadip. It's really a pleasure to see you.
Hope everything in Italy is getting back to normal.
Yeah, absolutely.
Okay.
All right. Okay, see you, Ray.
Bye-bye. Bye, Jadip.
Bye.
Take care.
Bye-bye. Okay, here's a question from Dr. Navarro. What other pre-op diagnostic procedures would you recommend in lieu of pH studies and manometry? I guess this would be directed towards Dr. Lawenko.
Okay, I think this was answered earlier by Dr. Rao in the chat box. So I agree. You can request for a barium swallow. He mentioned it's available. It's It's an easy procedure to do. It's not that costly. So what information you can get from the barium, of course, you want to see if there's any outright evidence of achalasia, which is what you want to rule out if before you want to do any type of anti-reflux surgery. I think, yeah, that's it. Barium swallow in our setting would be helpful.
Yeah.
In that sense.
So, yeah, so Dr. Jana, I'd just like to add that if the question actually implies that barium swallow can somehow help us in diagnosing reflux, well, it can if you do head down position, but then in some normal patients, this will automatically happen. So it doesn't mean that you can stamp reflux on the basis of barium swallow. It's only useful to exclude achalasia and motility disorders.
Yes, I agree.
Thank you.
Okay, we have a raised hand here among our attendees from Dr. Maunting. Would you like to ask your question? Hello. Okay. I think they probably hit the raise hand accidentally. So there's another question from Dr. Don Roselio.
No, it's not actually a question. It's just a comment with regards to pre-op evaluation. I'd just like to share, because last week I saw an old patient of mine who has a small hiatal hernia. She's a 51-year-old physician, female physician, who's actually the head of a family medical practice. And she's an old patient of mine who has a small hiatal hernia being managed medically. And last week she came in with, atypical symptoms, difficulty of breathing and everything. And I actually requested for I was thinking this hiatal hernia could have been gotten bigger or something. So I requested for a CT scan of the chest with some oral contrast, and it came out something like this. And obviously it was COVID-19. She was positive for COVID-19. So her difficulty of breathing and, her atypical symptoms was actually due to COVID-19. She was positive for IgM, and RT-PCR was positive, IgG negative. So it's one of those things that, maybe we would like to think about during this time.
Yeah.
Okay. I guess this question is for everyone. What sutures do you use during the application? I think with respect to the mesh, it's already been answered. The composite mesh. With respect to the sutures, I think it was mentioned during the videos also. The non-absorbable sutures. Any other questions?
Allenbert is the non-absorbable braided sutures. The FE bond is a lot easier to handle when you do your suturing with regards to the cruise and to the fundoplication.
Do you, I guess my question to the speakers would be, do you use nylon braided only, or can you use silk?
Silk was used earlier. I think I saw my teachers using silk, but we have moved away from silk in most situations. Ethibond remains the suture of choice in my hands, but I'm sure I've seen people using polypropylene. I've seen people using nylon. So I think it all depends on surgeon's comfort. But for us, it's the Ethibond.
Okay, thank you for answering.
I can share my experience. I agree perfectly. I use Avibond too. I think it's the best choice for this kind of intervention.
Yeah.
Okay. I Well, this was probably directed to Dr. Rao. I believe he answered this in the chat box. Uh, Anyone can. What was her? Okay. I guess we. Any other questions for our remaining speakers and panelists? Okay.
Albert, a very theoretical one to Dr. Lawenko. Any experience with regards to the endo flip, with regards to measuring or determining lower esophageal sphincter pressures?
Sir, when I trained, sorry, sir. Mike.
Mike Jr.
I was lucky. I was fortunate to be exposed. We had for a couple months endo flip in Malaysia. So I had a couple of patients we did it prior to POEM. So after we did the manometry, so we were able to determine achalasia. And then what we did, we just used the endo flip to measure the distensibility index, which is the parameter that is being used as a measure of sort of to find out if you do it. I think in some studies I've read, you do it before, you even do it during a poem, and then after, and then it's said to determine if your myotomy is sufficient in that sense. And we've had an experience, we used the endo flip, the ESO flip, we used it as a pneumatic dilator. So we placed it and then we determined the distensibility index, and then we did dilation in the same setting, and then we measured the index after to more or less see if the dilation we did was sufficient. So, but I think there are very limited studies at the moment with its use, but maybe if it's, I don't think it's available here, and I'm not entirely sure if in the rest of Southeast Asia it is available.
I asked the question because what's running inside my head actually is the endo flip is just like, when you look at your Senstaken Blakemore tube, it's almost the same. And since, as you mentioned, there's only one manometry testing here in the country, which is St. Luke's, one in QC. And then if you want to request for manometry in Global City, they'll just transfer the machine to Global City. So anyway, that's the thing that's happening with that testing. I was thinking if we place a Senstaken Blakemore GE junction, then attach it to some sort of a pressure monitor, just the pressure monitors in the ones that they use in the industry. It might just give us an idea how the pressures of the LES is just an experimental. Just my mind is just running with regards to this these things. I just maybe we can do something about study about it.
Yeah, but I guess the question would really be is what numbers are we going to be
talking about? Yeah. Okay.
Yeah. And possibly where are we going to use it? I think the important thing is, even if you have a hammer, where are you going to find the nail? So, endo flip is a very costly device to use. But I think there are two areas which I heard would be interesting in my mind. A, after dissecting the entire cruise and bringing the fundus back, to assess the LES pressure and decide whether you're going to do a Tupe or a Nissen. That's A. Two is if I am dissecting a paraesophageal hernia where the LES pressure itself is not known with the preoperative investigation, then after dissecting everything, to measure the LES pressure itself intraoperatively in a paraesophageal hernia after dissection, endoflip may be of use. So I think these two areas may be of importance. I'm not sure. I'm just speaking from what I've heard.
Another, Dr. Bai, Professor, a question with regards to sometimes when you repair that cruise, you'd like to bring in the left and the right cruise. Sometimes when you pass your sutures, one of those, most commonly the right one, would actually tear up. And there would be a portion of that right cruise that has actually a small hole or a small gap. Would you repair that, or you just put a mesh on top of it?
So, okay. So for me, if the crews are not coming together, we use pledgets to modify. But if the tear has already happened, I would go in and put in a mesh. I would not like to oppose them again. I would like to put in a mesh. But that's the patient who may have a RAP migration later on in life. So I would like to put in a mesh.
Thank you.
Okay. Okay, let me allow me to end this conference. Thank you everyone for joining us. But before we end, we'd like to express our sincere appreciation to all the speakers and panelists for joining us in this afternoon's event. Um, we have already sent out the e-certificate of appreciation, which reads certificate of appreciation awarded to the speakers and panelists for their invaluable support as guest speaker and speakers in this session on online UMIST conference on A to Z of GERD diagnosis to treatment. Signed by the chairman and MIS training officers of the three member training institutions, namely Dr. Romeo Abari and Dr. Joel Celaje, the fourth, respectively, for Quirino Memorial Medical Center, Dr. Ray Sarmiento and Dr. Eva Lourdes Santa Clara, respectively, for Rizal Medical Center, Dr. Alejandro Palines Jr. and Dr. Raymond Joseph Romero for Batangas Medical Center, also signed by the program director of UMIST, Dr. Alfred Allen Buenafe, and also the Palace President, Dr. Ernesto Tan. Will there be any parting words from the different training institutions? Dr. Abari, would you like to say some words, sir? Okay.
Hello. Can you hear me?
Yes, sir. Yes, sir. We can hear you.
Yeah. Well, in behalf of Quirino Memorial Medical Center, no, especially yeah, with our program director, with our very energetic Alan Buenafe, and with different chairmans, Alex and Ray. Yeah, I would like just to tell that it's a very successful endeavors, and especially for the lecturers, our guest lecturers, Dr. Baig, Luento, and yeah, Dr. Rao, and
Sino po ba? Yeah. Don Edwards and Dr. Carrara. Yeah, thank you very much for your very inspiring and lectures. It really helped us a lot, giving the best to our patients, especially here in the Philippines. And looking forward for another lectures like this. Thank you so much. And also to the participants. Thank you. Thank you so much.
Dr. Ray Sarmiento, would you like to say some words?
Well, I'd like to thank everyone, Professor Sarafas, Dr. Rao, Alessandro, Dr. Alawenco, Dr. Don Roselo. This has been a very interesting afternoon. Hopefully we learned a lot, and I think we want to see you again probably in 2 weeks' time or in a week's time with regards to another conference, UMIST conference. We maximize the time that we are able to do this. And thank you very much, everybody, for joining.
Dr. Palines, would you like to say some words?
Yeah, in behalf of the Batangas Medical Center, UMIST and the Quirino and Rizal Medical Center, we would like to thank all the speakers. It's a very informative afternoon, coupled with interesting videos. So I guess a lot of us, majority of us and all of us have learned a lot from this afternoon session. So thank you very much again to the speakers, and hope to see you again.
Thank you, sir. Dr. Buenafe, would you like to say some words, sir? Dr. Buenafe? Okay.
I saw Alan wearing the mask already for the OR, I think. Yeah, there is Alan.
Thank you, thank you. Sarfraz, my very good friend, Sarfraz, Alessandro, Jaideep, George Young was here actually earlier with Wayne Wang, Bernard Delamani. We tried to invite, but Bernard said he has something today. We would want to see you next week for our next series. Eileen, can you flash the next lectures for the next few weeks? We'll be offering CPD units by next week. We were already approved by PRC. So UMIST Group will now be a CPD provider for all our webinars. I would like to thank all the participants, all the lecturers, and all the panelists for attending. Thank you.
Thank you very much, Dr. Buenafe. Is everyone still here? Yes.
Thank you, everyone.
Thank you, everyone, for joining us.
Thank you.
Thank you. See you next week.
In behalf of Dr. Buenafe, I'd like to thank everybody for joining.
Thank you very much to you all.
Thank you.
See you next
Thank
time.
you. See you next time, Professor Carrara.
Alessandro, thank you. Sarfraz, see you
Alan,
next week.
Alan, you are the
Yes.
number one, Alan.
I love you, bro.
See you soon.
Grazie mille.
Grazie. Ciao.
Grazie. Ciao. Hey, Don Hercito is he's here. Hi, Don. Also, Ike Mendoza.
Ike Mendoza also is online, I think.
They should be the panelists. I don't know why they want to hide. Thank you. Thank you.
Thank you very much.
Thank you, UMIST. Arlene, Alex, Allenberg, Eva, Santa Clara, Joel Selaje, RJ, These are the people actually that works and run UMIST. Maraming salamat. Maraming salamat.
Malamig ba dyan sa San Francisco?
Nasa ward na kasi may pasyente din.
Okay. Sige. So next week ulit, guys. See you again.
Salamat.
Thank you,
salamat.
Dr. Buenafe,
Okay.
for organizing this.
Okay, ingat everybody.
Dr. Cueto, by the way, wants to do a lecture on the new normal on skills. I'll try to get one of his lectures also. So let's watch out for that lecture series. Bye.
Joel, thank you.
Thank you, sir. Thank you.
Thank you, everyone. Thank you. Thank you.
Dr.
Oh,
Amari.
gold na. Gold na tayo.
Diyan na, sir, sa sisigahan, sa likod.
Okay, thank you so much. See you next week.
Okay, sir.
Bye-bye.